Good afternoon. We'll start the afternoon session of Labor, Health, and Social Services. This morning, we did not get to maternity care provider issues, so we will begin with that. What I would ask is if there's a topic that a place where someone has already mentioned your thoughts and your information, would you please just consider that? And we'll see how much public testimony there is, but we may limit the time. So we'll see how that goes, but we're glad that all you are here. We've received a lot of good information this morning, and these topics are very important to each and every one of us. So thank you. We'll begin with maternity care provider issues. I see that the Department of Health is up first, and Deputy Director, yes, Franz.
Thank you, Madam Chairman, members of the committee. Again, my name is Franz Fuchs. I'm the Deputy Director of the Department of Health, joined here by Monique McBride, who's our Business Operations Administrator. Here to give a brief an update on maternity care issues in the state, sort of on a broad basis. And Monique's going to get the slides up on the screen, but we're going to start. Slide 4 is the agenda here. So I'm going to cover some of the Department of Health programming that deals with obstetric and maternity care generally, Medicaid, WIC, and public health nursing. We'll display some updated trends on maternity deserts. And then we'll talk about some policy implications that this committee may want to look into during this interim. And if there's questions at any time, Madam Chairman, happy to stop and take and field those. So moving on to slide 5, now we're talking about Medicaid and CHIP. This is sort of a summary. Actually, there's a summary of all our department programs here. Medicaid and CHIP generally offers health insurance for pregnant women and newborns and children. And you can see that's on an income basis. So below 154% of the poverty level. Don't quote me, but I think 100% of the poverty level is around $15,000 now. I have to look that up and get it to you. But that's kind of ballpark what income we're talking about. Generally speaking, children are going to be covered by Medicaid or CHIP under 200% of the poverty level. And pregnant women will be covered for 12 months postpartum under 154% of the poverty level. In addition to Medicaid, we have in our public health division the Women, Infants, and Children program, which provides subsidizes food at grocery stores. So there's a nutritious food package that's available for mothers and their kids. But they also do nutrition education and breastfeeding support. And then we also have programs in the public health division that do infant home visitation and newborn screening. So quite a wide variety of support activities for mothers. As I mentioned in Medicaid, once mothers are eligible, now we're on slide 6, coverage is continuous throughout the pregnancy and then through 12 months postpartum. And that's bolded because that was a relatively recent change the legislature made. And there is a sunset of that coming up. I'll talk to on the next slide. That will be a policy consideration for this committee and the legislature as a whole. Medicaid coverage is fairly comprehensive as far as health benefits go. And it is a very generous plan. There's no co-pays or other cost sharing involved. So on slide 7, we talk about the postpartum extension. That would happen in 2023 as part of House Enrolled Act 84. The important thing we want to note is that in 2027, eligibility for that postpartum coverage will sunset. So we will, without further action, revert back to only 60 days postpartum coverage. And so that is in Section 2 of that act. And we would recommend the committee at least consider a bill to modify that sunset date or repeal it if the legislature wishes to continue the postpartum extension. This is the only thing we would require. We have the budget to maintain this, so we would not need any additional funds to maintain the extension. It's a legislative sunset that is at issue. Just some updates on the next slide, talking about how enrollment and costs have trended in the pregnant women category. There's a lot of things that have happened in Medicaid since 2016. What you'll see on the slide are the two stacked graphs. The time on the x-axis ranges from January of 2016 to January of 2026. So it's 10 years worth of data. I've bracketed the significant growth in enrollment that happened during the public health emergency, during the COVID pandemic. Medicaid was prohibited from disenrolling people off Medicaid. So we kept people on, and so new people coming in basically increased that enrollment per that curve you see. And then as soon as that public health emergency ended, we conducted what's called the unwinding, which is reverting eligibility back to its previous status. And you can see how eligibility and enrollment has dropped since then. But because we have the postpartum extension now, which happened in 2023, enrollment's at a higher base level than it was before. So before we were at around 1,500 mothers on Medicaid at any given time, and now we're around 3,000 mothers at any given time. And that's simply because they're on for longer. So the enrollment on a monthly basis increases. I just want to note here when we projected this and presented the postpartum extension back in 2023, we had projections on what enrollment would be, and it was around 2,750. So we were a bit too low. The actual enrollment experience has been 15% higher than we expected. However, the budget has been fine. We have had no issues staying within budget to maintain this program. When you look at the graph on the bottom, this shows what's called per member per month cost. It represents an average monthly cost, very similar to if you were paying a health insurance premium. The monthly premium cost kind of includes all the health expenses you would expect for that population. You can see before the COVID, our per member per month was around $1,100. And that was largely because giving birth is a predictable and expensive event in this population. And that sort of encompasses those costs as well as the prenatal and then limited postnatal benefits that were included for that population. Now during COVID, you can see the per member per month drops because now we're keeping people enrolled in this pregnant woman category, even though they have long passed their pregnancy. Their health utilization drops to sort of an average younger adult kind of level. And so the per member per month cost drops. You can see during the COVID. And as we start disenrolling people, it starts going back up again to kind of where it previously was. So I don't want to bore people with the details here, but that's kind of trying to explain why that trend is fluctuating. The important thing to note is the PMPM now is a blend because we have women staying on longer after giving birth. Their costs drop down. They're relatively cheaper to insure at that point. And so that's why the per member per month will likely remain lower going forward than it was in the past. So it's just sort of a matter of concentration, how concentrated the healthcare costs are in this population. That's all that is trying to communicate there. I would note there were, of course, some rate increases. So the legislature in the past few years has approved rate increases in various benefit plans for Medicaid. And so those kind of get factored in here as well. So for example, the most recent one this last session, of course, for critical access hospitals providing maternity coverage, that will increase rates further for those providers as well as obstetric physicians and other providers. Those rates are increasing as well. So the PMPM will increase slightly in the coming years. But generally speaking, the bottom line is we believe we certainly have the budget to maintain this program going forward. It really is, the issue is just that sunset date on slide 7. As far as children go, the newborn Medicaid benefit, those kids are automatically eligible for the first year. Comprehensive benefit package, again, very little cost sharing. Those kids don't make a lot of money, so it's hard for them to pay those copays. But most of those kids will transition to the regular Medicaid CHIP or KID program after that newborn first year period. And then eligibility going forward from there for ages 18 and under is based on various income levels. But at the end of the day, CHIP kind of covers above Medicaid up to 200%. So essentially, any kid under 200% will be eligible for Medicaid or CHIP. And they're essentially, at this point, the same plan, same benefit plan, same structure. So the bottom line here is that kids under 200% are covered by that benefit.
excuse me, Director, if I might just for clarification. So am I to believe that any young person under the age of 18, that their parents are on Medicaid, then they are covered by Medicaid? Is that?
Madam Chairman, it would be if their household income is below 200% of the poverty level, the kid would be eligible for Medicaid. In many cases, and probably in most cases, the parents are likely not eligible. Slide 11, shifting gears a little bit, just shows an overview of how births have trended since we put 2008 as kind of a reference at the top, but we skip just for brevity. Brevity in a relative sense. We only include 2015 to 2024 on this slide. So you can see the percentage of births that were paid for by Medicaid has decreased from around 42% back in 2008 to around 35% today, and that's been fairly steady for the past few years. I think another important trend to note here is the demographics. If you look at all births, there's a certainly declining trend there, right? So we used to have 8,000 newborns a year in Wyoming in 2008, and now we're down to around 6,000. Slide 12, now we're shifting gears again to talk about the public health programs. I sort of talked about women, infants, and children, what they do in the overview. This slide has some statistics on enrollment currently. So right now we have 676 pregnant women, of which 602 are breastfeeding, 400 are postpartum. And there's, in addition to those women, there are about 1,700 infants and an additional 4,600 kids. So that's enrollment in the WIC program today. And the final Department of Health program I'll talk about is the public health nurse infant home visitation. Show the authorizing statute there. This uses a model to basically have a public health nurse visit mothers shortly after birth to really try to help them with breastfeeding, referral to what services might be available, and just general education and trying to help, tips for safe sleep, trying to help new mothers. It can be a very difficult time, I think, as any parent knows, those first few weeks. So this is a program that helps those new moms out. And you can see our current caseload is 527 out of 720. So, Madam Chairman, I'll just pause there real quick before we get into the maternity desert to see if there's any questions about home visitation from Senator Scott, potentially.
Yes, Senator Scott.
Yeah, Chairman, on the home visitation, I can remember when we passed that law, the intent was to use the Olds model because there was that tremendous randomized control trial test showing very, very good results long term. The initial legislation had that anyone who gave birth on Medicaid was the eligible population we were trying to reach, because the research showed that only women who were young, poor, and unmarried were really benefited from the program. Is that still the definition, or is it has it changed?
Madam Chairman, Senator Scott, my understanding is that's still the definition and the target population. The biggest challenge with this particular program is there's obviously a lot more Medicaid eligible women, and of that, we're only reaching a relatively small fraction. So the outreach component has been difficult. That's probably been the biggest challenge for this program. But I can certainly get you more information on how that funnel works, how many women were contacted, which ones were contacted, was it primarily Medicaid, and how many of them, actually ultimately ended up being enrolled, if that would be helpful.
Madam Chairman?
Senator?
Yeah, that You just look at the number of Medicaid births. If that's the criteria for being eligible, I don't know where your 720 figure is, but it looks to me like you're reaching about 15% or so of the total population that would be eligible.
Madam Chairman, Senator Scott, the possible caseload is actually based on the staffing that's available, based on how many public health nurses there are. And we have a significant number of vacancies there. So that's kind of our maximum caseload that we really foresee being practical. That's what that number
So,
represents.
but you're simply not reaching most of the population.
Correct. Yeah. I think,
Director.
Madam Chairman, Senator Scott, I think we are reaching, at least contacting initially, most of the population. It's a matter of these are actually enrolled in the program long-term for whatever reason, if it was they didn't want to participate or we lost contact. There's probably a variety of reasons why mothers may not choose to enroll in this program, but I know we do strive to contact virtually all Medicaid mothers.
And you're no longer using the olds model because you're just talking about essentially 1 or 2 visits early after birth. And that model preferably had some pre-birth visits and extended out 2 years. You're doing something different than that now, right?
Madam Chairman, Senator Scott, we are, and I can get you more details on exactly how the model compares with that RCT model.
Madam Chairman,
Senator Scott.
this is an area the committee might want to think pretty hard about. The health department's program has never been very successful because they haven't reached a lot of the people. And if we really wanted to do something, I think we'd have to go to a private contract that didn't pay if they didn't reach. There's some real problems here.
Representative Thayer.
Thank you, Madam Chairman. Question for a little clarification. So on the birth trends, Director, Deputy Director, we have a 25% decrease in Wyoming from the 8,015 and 2008 to the 2024 stat. So it's about 25%. But if you pull up the national, it's 15%. Do you, and this is just speculation on our maternity deserts, do you think it's from our maternity deserts and people are leaving the state? Just a very open, broad question, but I think it's interesting. The national average is 15% from 08 to 2024, and we're at 25%. Any thoughts?
Representative Chairman, or sorry, Madam Chairman, Representative Thayer. I don't know exactly what might be causing what, but I would suspect that there's probably mutually reinforcing loops there. So maternity deserts would maybe cause people to not, or to drive them away essentially, to not give birth in Wyoming, but also not having those births may cause the maternity deserts because there's not volume enough to support the service in that area. So there may be kind of like a loop where both cause both over time. But that's just sort of speculation on my part. I don't have any evidence to suggest that aside from, the maternity deserts we see and the birth trends we see.
Okay, thank you.
And Deputy Director, I do have a question myself. With this women, infants, with the WIC program and the people that are serviced, do they need then to apply? It's not like the health department goes out and offers, all these services to Medicaid eligible women or WIC eligible women, but they have to themselves come to the Department of Health to get these services. Is that correct? And then with the second question I have, can you give me an idea of, because we're saying that there's lacks of service in counties, how many counties do have public nurses and how many do not?
Madam Chairman, we do have public health nurse offices in every county.
Okay.
Some of them are state operated, some are independent. and some operate in this hybrid model. But at the end of the day, the staffing of nurses within those offices may vary. And so their ability to provide services can certainly vary by county. And I don't have a distribution off the top of my head, but we could probably provide that to you.
And then just to follow up with that, how, when we say that we have home visitation, how is that done? Is that just random or by appointment, or it has to be requested? How is that done?
Madam Chairman, my understanding is that we know which mothers have given birth either through vital statistics or Medicaid data. We do reach out to those mothers and see if they're interested in these services. And if they are, at that point, we'd schedule those appointments for that infant home visitation program.
Thank you. Any other questions for the Deputy Director? Okay, I guess Senator Scott?
You open the questions on this maternity desert slide?
As soon as they present.
So Madam Chairman, proceeding on to slide 14, the word maternity desert, I think originally came from the March of Dimes. So we put this up here just as sort of the source for what they call a maternity desert, as far as having no birth hospitals or birth centers and no obstetric providers. And for the past couple of years, we've tried to create a little bit of a more nuanced definition of that, to try to make it a little more updated. And so slide 15 shows our map of the state, where we have multiple categories of desert. One of the first, the dark brown, is what we're calling long-standing maternity deserts, where there really has never been the capacity of a hospital to have labor and delivery there. So it's not like people move to, Crook County expecting to be able to give birth at the local hospital. That's just never been a possibility. And those are the dark brown. The more of concern are the sort of medium brown, which we're calling new maternity deserts. And these are county subdivisions where recently, at least in the past few years, a hospital with a labor and delivery unit has ceased operations. And so you can see here that, Riverton gave that up, I believe, in 2018. We have Rawlins and Wheatland, Kemmer, and most recently Evanston, all abandoned labor and delivery services. And so that's why those counties are colored that medium brown. And then we have a sort of a light beige color for what we're calling a warning. And that's just when we've seen a trend in births that is decreasing in that particular area. And that's in Lander. We've seen mothers choosing to give birth in Thermopolis or other places instead of Lander. And so the decreasing birth trend there is just something to keep an eye on for something that may come up in the future. So that explains the colors. And you can see, I described that on slide 16. But when I presented this last, Senator Steinmetz, who wasn't here, she expressed some concerns about being dissatisfied by, basically assigning the whole county into a maternity desert. So we took that criticism to heart and we tried to take an alternative approach. And so the next couple slides show what we tried to do is look on a much more granular basis and look at how the driving distance for an uncomplicated birth has changed between 2018 and 2025. And that slide really shows the biggest impacts as far as, the colors you can see, with the southwest corner of the state having probably the most significant impact. And I think the nuance, what's interesting here is, for Wheatland and Rawlins, a significant fraction of the mothers were actually going to different hospitals before those services were abandoned. So in 2018, a lot of people in Rawlins were going to Laramie already. And so when that hospital closed, the average driving distance didn't actually change as much as you'd expect, because the previous status quo was they were already going to Laramie anyway in many cases. And that's why the colors for Rawlins and Wheatland are not as intense in that area, even though you'd think, based on the travel time, that the driving distance would be significant. So that was an interesting nuance to bring up to the committee, that the degree that a hospital was, how many mothers were choosing to give birth at that local hospital makes a difference as far as what that shock ends up being. And then just for reference, the next slide just kind of shows for each of those areas sort of an average driving distance for an uncomplicated delivery. So, from 0 to 30 being the very light yellow to 150 miles plus for some areas in over the hill from Saratoga, Bags area. So, Madam Chairman, we thought this might be just a little bit of nuance to the conversation that you're all having on this important topic. And then on slide 19, we just show, again, some updated trends. This is updated for 2026. Each of those dots is the number of births that happened at a particular hospital, and the red line shows the trend over time since 2016. Of note, you can see the, Carbon County, Carbon County Memorial shutting down its deliveries, labor and delivery around 2023. I thought with Wheatland beginning to close down its labor and delivery, you can see a lot of those births going to Converse County. You can kind of see that shift there in that graph, which I thought was interesting. Cheyenne didn't see as much of an uptick. And then other than that, and the Lander Hot Springs County dynamic, those are the main trends that we've noticed on this graph. But this just shows kind of how some areas are relatively stable and relatively low volume. You can see Worland and Torrington, both have relatively low birth numbers, but have been relatively stable since 2016. While there's been a general demographic trend to have fewer births overall. So, Madam Chairman, I'll just pause there to see if there's any questions on these data slides before moving on to the policy piece.
Senator Scott.
Several questions. First one, just understanding this slide on the hospital delivery trends. That's deliveries per month or per year. What's that one axis?
Madam Chairman, Senator Scott, it's per month. So these are monthly deliveries, and each dot represents a data point for that particular month. And then the red line is the trend over time.
Okay. And
Senator Scott.
what's the places that are having economic trouble? What's the cost structure that's leading to that economic trouble? Because you got deliveries, and then you've got cost, and what's making them unprofitable? Are there high fixed cost problems, and if so, in what area?
Madam Chairman, Senator Scott, I'm sure there's a lot of hospital folks here that may be able to answer that better than I can. My understanding is that when you have relatively low volume of births and you have to maintain, ideally you'd want 3 providers on standby in that community who can deliver babies, because you don't want to burn, if you only have 2, you burn them out pretty quick. And so having to recruit providers, particularly if you have a locum tenens that you're paying, potentially hundreds of thousands of dollars for that person just to be there, to be on call for deliveries, I think is a pretty significant fixed cost. We've heard also that, for them, it's been said that malpractice, rates are also a factor, particularly for obstetric providers. But we don't really have any hard data on that either way. So my understanding is it really comes down to being able to have the providers who can actually deliver the babies in that community. And if the hospital doesn't have those, it spends significant expense to try to recruit them in order to maintain that service.
Madam Chairman.
Follow up, Senator Scott.
I would like, and maybe people coming up behind him can answer the question. I'd like to know how much is the usage of the locum tenens, because that would run the cost way up. How much of that is there across the state? And to what extent does the malpractice problems cause the high fixed cost? And what else is going on that's making it difficult from the cost standpoint to provide these services, Madam Chairman? Because I think that's understanding what we might want to do about this. That's going to be critical.
Good questions. Thank you, Senator Scott. Deputy Director, to go along with that, the malpractice insurance I know has been a hard thing. I don't know the department. Hospital Association probably has that. But I was wondering too, in these statistics that you've given with the Medicaid and the trends, Is the Wind River Indian Reservation, is that population included in these, or does that go along with the Indian Health Services with the Fed?
Madam Chairman, I think it'd be included in both. The hospital delivery trends you see on this slide, slide 19, are all births in Wyoming. So we actually use vital statistics data for this. The Medicaid models for delivery, I think, would also include a significant number, if not all, the Native American population, because they would many would qualify for Medicaid. And so they're not excluded from Medicaid by any stretch. And so they don't necessarily would use IHS facilities. Or bill IHS, we would definitely see a significant number of that population in Medicaid.
Senator Hutchings.
Thank you, Madam Chair. Few of my questions have been answered, which is very good. Franz, I'm wondering about you're tracking the number of births and the reason why it's down. And then are you tracking the doulas, the midwives, and the home births to see if the population is just shifting? Hey, we can't find a doctor. We live somewhere where there isn't a doctor. We're choosing to do that. So what's the data on those three groups, the doulas, midwives, and the home births? Just mom and pop saying we're going to just do this at home.
Madam Chairman, Senator Hutchings, that's a really good question. The data here you only see hospitals. I think it's an interesting question to see whether how the trend in home births or birthing centers has changed. That's certainly something we could look at. I think we have the data from vital statistics to the extent that people do request birth certificates and submit those forms. I think we can get that data and try to get it to you shortly.
Thank you.
Thank you. Any other questions at this time? No? Okay. You want to proceed?
So, Madam Chairman, just the final slides here talk about the policy aspect of things. So from our perspective, slide 20, this is really a hospital viability issue. Particularly for labor and delivery, there's almost a existential aspect to this, right? If a small town, if you can't give birth in a small town, I think that can be very bad for the future of that town. It's almost like infrastructure, like, roads, sewer, water. People expect to be able to, turn the light on and have electricity, right? I think a lot of families would only move to spots where they can expect this kind of care from their local hospital. So I think there is a need for this service that's kind of goes beyond just the standard menu of hospital services. It really I think there's an aspect to this where hospitals become an anchor for a community's future and being able to support families living in that community. And that's why at the end of the day, all the infrastructure around births kind of coalesces around the hospital. The admitting privileges for all the providers, whether they're, physicians or midwives or nurse practitioners, all the infrastructure and for delivery, the staffing, and not just for the uncomplicated births, but for all the capability to deal with complications as they arise. There's a backstop aspect of a hospital, right? You have to have the hospital because if something bad happens, who's gonna deal with that? That's I think the value, not just the giving birth in a hospital. It's the capability to be able to deal with the complications is also really important to consider. So at the end of the day, that's kind of what we see as this really critical role as being this community anchor for labor and delivery generally. The closures themselves, obviously, no one wants to close these services. No one wants to shut down a labor and delivery unit. They really are a symptom of financial distress. They're a symptom of basically load shedding. If you have a power plant that's overloaded, you have to, figure out some way to balance the load. And I think from a hospital perspective, they will look at their most unprofitable cost centers and take those offline first before they have to take off the things like, the emergency room, right? That's going to be a higher priority. So at the end of the day, we see it as a symptom of a problem, not necessarily a problem that is intentional. So the question is why are hospitals experiencing financial stress? Slide 21. These are our theories. I think it would be very good for you to talk with your local hospitals, to talk with folks here and get their perspective. But we see higher costs. So particularly post-COVID, there's been significant increases on stress on the nurse labor market and increased reliance on traveling nurse agencies. We as a department face this, know this intimately with our 5 facilities. We have contracted traveling staff, and that those costs are significantly higher. Provider recruitment as well for physicians and other providers, like the locum tenens issue, we mentioned a few minutes ago, also very costly. At the same time, you have decreasing volume, right? You have a shrinking population, fewer women of childbearing age. We see that demographic trend in fewer births. From a department perspective, Medicaid rates are, we are a relatively significant payer here. We cover around 30%, 35% of births. And you can see we pay much less than the average when you sum everything up, the provider rate and the hospital rate, than private payers do. So I would say that average private pay is probably higher now. But at the end of the day, Medicaid rates, even though they are increasing, will still be much lower than private pay rates. And finally, we have seen, in some cases, the financial stress is due to management issues. Certain hospitals have seen a rotating cast of hospital management companies and CEOs and CFOs that don't seem to be fixing problems. And that is also an issue that I'm not sure we have a particular prescription for, but is, I think, of note when it comes to these difficulties. So policy shifts that are relatively recent, you can see just this last session, the legislature appropriated $17 million for the biennium to increase rates for smaller hospitals that offer labor and delivery services. I think we hope this provides a incentive for hospitals to maintain these services and potentially bring them back if you're being paid your costs by Medicaid if you do this one thing. As well, the legislature did appropriate additional funds for providers, for obstetricians and family medicine physicians, midwives, and other providers who actually deliver the babies. So those provider rates have been increased as well. So those are, I think, very positive, and we certainly appreciate that from the Department of Health, from the legislature. Rural health transformation may also help here. We do have numerous initiatives that are really targeted to incentivize hospitals to provide these services. And so at the end of the day, we're optimistic a deal can be had with CMS. And when that happens, we will roll those out. But we, as part of that, hospital package, we are going to be strongly incentivizing the provision of labor and delivery as well. So at the end of the day, what we're trying to do as a state is, as an executive branch agency, as the payer from any of these things, is to put the incentives in place so hospitals respond and hopefully see that incentive and respond appropriately. That's our objective.
Questions? Representative Clouston.
Thank you, Madam Chair. Thank you, Mr. Fuchs. So I want to go back to what we did last year, the budget session. So we appropriated $22.2 million in state general funds. First question is, are those exactly matched by the federal funds? And then secondly, if we were paying $7,500 per Medicaid birth, what are these additional funds? Do you know what that payment will go up to compared to the private payers?
Madam Chairman, Representative Clouston, so yes, that we get an exact federal match 50-50 for these services. There's no special match that we get. So this is, again, these figures are for the biennium, and they're all inclusive of both the general fund and the federal funds. As far as the rate themselves, it's going to be a little complicated because these inpatient rates, for example, are for all inpatient services, just for critical access hospitals that do labor and delivery. And so the number of births that happen in those critical access hospitals is probably a lot lower than the births that happen in Cheyenne and Casper and in Gillette, Sweetwater County, so on. But although Sweetwater County is is converting to a critical access hospital. So that's a long-winded way of saying I don't know how that rate's going to go up and how, but it's definitely going to be changed. It's going to be differential across providers, right? So these smaller critical access hospitals will get a higher rate per birth on average than the larger hospitals will, just because this incentive is structured that way.
Senator Scott, did you have a question?
I think the same question just answered to
Okay.
the $7,500 per is the older figure, and you don't know what the new figure is going to be. Is that right?
Madam Chairman, Senator Scott, that's correct. We can get you an estimate, I think, soon, but I don't have that number exactly.
Representative Yin.
Madam Chairman, thank you. Mr. Fuchs, what's our average Medicaid payment for surrounding states? Do you know that for labor and delivery?
Madam Chairman, Representative Yin, not off the top of my head, but we can get that to you. We do a benchmarking analysis.
Okay, I think, public comment? No? No, not on this. You want to wait till we're done? Any questions for? Oh, question. Yeah. Committee, do you have any more questions? Are there any on line? No. Okay, any more? No? Okay, Wyoming Board of Medicine. And thank you, Department of Health, appreciate it. Good presentation. Welcome. Did you provide handouts for us?
I provided one 11th hour, and it's not very fancy. It's nothing like Mr. Fuchs has, but it's got colors. I'm pretty proud of it, so. It's just a grid with numbers.
I don't seem to, oh, that one. Okay. Okay, has everyone found their sheet? Okay, thank you.
Certainly.
Please proceed. Introduce yourselves first.
Madam Chairman, Kevin Bonenblust, Executive Director of the Board of Medicine. The board licenses and regulates practice by MDs, DOs, and PAs. And I don't have a deck of slides to show you or anything else. Mostly I want to be here to provide some information, maybe a little bit of background on where we've been and where we may be going with physician licensing and recruitment. Before I get into that, there were a couple of questions raised about residency programs, and I'm this morning, and I'm by far not an expert on those, but a couple of the points is that I believe Representative Clauston noted that the third year residents then get full licensure. And that's because they've met all the requirements for full licensure. So we say, okay, you're going to be licensed now. Let's get you a full license here. That way you've got a fully licensed physician. And I can't tell you for sure, but I would suspect they're going to get the full reimbursement on things. So they've got more autonomy and everything else because they are now qualified for a full unrestricted license, having completed 2 years of postgraduate training, et cetera. So we move them out of that training license category into full unrestricted. So that's what happens those third years. And I really am on thin ice here, but I think there's a big federal component to what how residency programs are funded. I think that's one of the big limits. You may have heard about shortages of residency slots because there are, especially medical schools in the Caribbean and so on, that buy up slots basically for their graduates. And then it makes it harder for the U.S. graduates to compete. Now, that was a big problem a few years ago. I think it's kind of waned a bit, but still, you're always going to have a bunch of people who've completed med school who have not matched for residency program. We don't really, except for the training license, we don't deal with them much in the residency. But the one thing I have sort of heard anecdotally is that one of the reasons it's hard to fill family medicine residency slots is because when they get out, they don't make as much money as other specialties. You know, and by the way, if you don't want to take call, well, probably family medicine isn't the place to be. You know, dermatology, that'd be a good call, or something like that. So that's another one of the issues you have with family medicine physicians. And I wish I had numbers for you on how many of our family physicians are actually practicing OB as well. We don't have very deep data. We're in the process of changing our licensing system vendor with one of the big goals to be able to squeeze more data like that out that we can give you. But at this point, I can't break out how many of our family medicine docs actually actively are engaged in OB practice, although they can by their license. I'm going to do a quick rewind here, and to steal from Yogi Berra, this sort of feels like deja vu all over again, because I remember appearing before this committee 18 years ago, and it was actually June that year, but we met, and I got to follow after the state Medicaid medical director had told this committee that the biggest barrier to getting physicians in Wyoming was licensure. And then I came up and had to answer for that. And the then chairman, a fellow named Charlie Scott, took me to task and said, you know, if you don't get this figured out, we'll just figure out a way to do it for you. So my board really has worked hard at this basically since 2008. We've streamlined everything we possibly can internally, but the real push we made, and it's paid off unbelievably, is the Interstate Medical Licensure Compact. My colleagues are tired of hearing about it, but it's been just an absolute ridiculous success for us. We were the first state to adopt it. We helped write it. We did all that. We got the ball rolling, and we were one of the first states in, and obviously it's the first one adopting. And I honestly thought that maybe 10% of our license volume would come through the Interstate Medical Licensure Compact, because we had no idea. I will tell you that last year, 63% of the licenses we issued were through the Interstate Compact. And in case you think we're stealing from one hand to pay the other, what I'm going to show you is if you take a look at my chart, and you can see fiscal years, because that's how we keep track for annual reports and everything. And you can see it in 2017, in that second column, we licensed 483 doctors. Fast forward to last fiscal year, and we're at 1,400, more than 3 times as many. So we've had some major changes, and a bunch of that has been because of the compact. You'll see then column 4, total physicians licensed in Wyoming, going from 3,773 to 7,690. So we've doubled the number of physicians holding a Wyoming license since 2017 when we started the compact. Now, I know the focus of this committee is obstetrics care, you know, and so on. And so we looked at it and said, how many OB-GYNs do we have licensed in Wyoming 2017? We had all of 89. We now have 297. So you've got a tripling of the number of OB-GYNs we have licensed in the state since 2017, which that tracks pretty much with the overall population increase of licensed physicians. But here's the last 2 columns give you the really interesting story. In 2017, basically half of the OB-GYNs we licensed actually had a Wyoming address. They were here. We knew they were in Wyoming consistently. Fast forward to today, even though we've tripled the number of OB-GYNs licensed in the state, we've barely doubled the number that are resident in the state. We're only at 29% of them now resident in the state. And I think that that's an indication of sort of the limitations of licensure and what you can do. Because we could license every OB-GYN in the country, but first off, every other state also has physician shortage areas. And even the most populous states, you get like into upstate New York, Western New York, they're going to have physician shortage areas. It's the nature of the beast because of distribution. And so that's what we're really bumping up against. We are not resting on our laurels, though. We are still working on looking at what else we can do, you know, get rid of the things that don't add value. But one thing we did look at this year with Representative Wasserberger was licensing of physicians trained in foreign countries who right now are not qualified to license in Wyoming. And we had a pretty good bill crafted. I think the budget session kind of chewed it up. And so it may come back. I think the bill may be even better next time. That's not going to add a lot of bodies, but at least it's an effort. If we add 10 physicians in Wyoming, I'll be surprised. Just because other states experience with that licensing foreign trained physicians, I think the largest number in any state was 45, and that was something like New York. So you translate their numbers to us and you see you're not going to see a huge influx, but it's something to help. So that bill, I think you get a chance to move it forward next year. I think it's a worthwhile effort. And then separately, there's been mention of the physician assistant licensure compact. And that requires then also speaking to what physician assistants are now able to do. And Representative McCann could probably tell you better than I can, but about 3 years ago, former chairman of this committee, again, Senator Baldwin, ran a bill to allow PAs independent practice. We're one of the few states in the country that PAs do have full independent practice. I'll still get calls from out of state. "Well, you mean they don't have to have any supervision?" Nope. They're a full provider, and you need to reimburse them as such, et cetera, et cetera. And so that has been interesting because it has been reflected in about a doubling of our licensing of PAs in this state. Now, unless you think it's going to be all this great stuff about family practice and everything, both the increase in doctors and the increase in PAs, there's a certain amount of it that is basically the telehealth get rich schemes. I'm going to prescribe GLP-1s and just do it by telehealth. And I'm going to charge out the wazoo for it. And I'm going to make lots of money. Or I'm going to prescribe ketamine for depression, even though that's pretty sketchy, but you do it interstate and they get national or licensed in multiple states and do it. So there's an element of that. But I do think, and there's another element of getting into Medi-Spas, which is something else that kind of drains off from our license numbers. Well, yeah, I'm practicing medicine, but I also spend half my time running a Medi-Spa. So the numbers get kind of weird. But what I would say is that by and large, though, that we are seeing an increase in providers that are providing care in Wyoming, but it's not full-time and it's not by being residents. It's been a telehealth model that has really taken off. And another one, there was discussion of locum tenens models here. And for those of you who don't speak doctor, locum tenens is basically a temporary assignment someplace. Let's say you have a physician who goes on maternity leave, you need somebody to fill in for 2 months. You bring in somebody with that specialty, they cover that practice for the 2 months or whatever. Or you know you're gonna have a gap, so-and-so is retiring and you want to do a search, you fill the gap that way. And that has been the tool that our hospitals have had to use a lot, I mean, for all sorts of reasons. And yes, it is expensive to hire locum tenens physicians because just think about it, a hired gun coming in, they're not going to come cheap. But one interesting development has been practices that basically they're from another state and they rotate the physicians in and out of Wyoming. So a physician comes and works in Wyoming for 2 months or 2 weeks and then rotates out and somebody else comes in from their practice. So there's still coverage for that hospital, but it's not going to be the same person 52 weeks out of the year. So there's some models like that that are out there. I think some of those things hold some promise. If we can look at some of those because the problem is trying to get an OB-GYN in a community, first off, as Mr. Fuchs pointed out, you only have one, you're going to burn them out in a hurry. You can only come out so many nights in a row delivering a baby and suddenly you're done. And so you really need to have at least a couple people who can do that. And so that's one of your challenges. But in that, that's one of those things you have to overcome is that a lot of our communities only support basically 0.4 full-time equivalents or 0.3 full-time equivalents. And I've yet to figure out how we can split an OB-GYN and have 0.3 of them go here and 0.4 of them go here and 0.3 go. It's the nature of our market. Our market is not big. And this is very specialized care. So that's one of the things we really run into. And then another one that we always see, and you don't hear much about, but it's after 1 or 2 years and the new physician cycles out and they're gone. Now, they may be getting a chance to do something bigger and better and shinier lights, but oftentimes they're happy to stay, but the spouse doesn't want to stay another winter in Wyoming. And if you think I'm kidding, trust me, it happens. You just ask any of your hospital administrators, I think, and it's tough. So we've got some things that we can't change. Geography, population size, weather, heavens. But I think the things we can do is encourage some different approaches to things. And one of them may be, I know at one point there was a discussion of regionalization of some of this care to make sure you've got the expertise you need at the right time at the right place. But knowing that already we've got communities that can't provide childbirth cares. They can't do it. And so how do we adapt for that? So I think from the Board of Medicine's perspective, I think it's going to be one of those times when I think we're all going to have to start looking at stuff and say, okay, that's how we used to do it, but what can we do differently? Because expanding scope of practice, all those things, that's nice, but really fundamentally at the core, we've got a problem. And so I can get all the OBs in the country licensed here, but getting them to provide services consistently is going to be really hard. I don't mean to sound negative there, but it's just, that's what we're up against on numbers. So don't mean to be a downer on that, but if you have questions, I'd be happy to answer them, or if you'd like me to go away, I'll do that too.
Any questions, committee? Representative McCann.
Thank you, Madam Chair. Just what my practice does is, we have docs that fly in. So, ortho's a little bit easier to do as far as that goes, but has there been any thought process on, these, basically this is going to sound terrible, but it gives them an excuse to use their planes. So they come flying in, they do clinic surgery. Some of them say a day, some of them say 2 days, and then they fly out. I don't see why you couldn't do that with other specialties. I don't know if you've thought of that or everything. I mean, that was kind of an organic thing. It just happened. And it was just, honestly, it was docs wanting to use their planes. So.
Madam Chairman, Representative McCann, yeah, there's something about orthopedic surgeons and their airplanes. They really like them. And that's one of those models it's especially suited to, because you can schedule surgeries and everything else. You know when you're going to have to be in Douglas to perform whatever surgery. Babies don't schedule so well, right? A lot of them just decide, oh, it's a snowstorm, I'm coming now. But there are practices like that, and we see that from a lot of the specialty hospitals around us too. An example is I think Colorado Children's does bring specialists like up to, they used to bring them up to Gillette, and they would fly in, do their thing, and then go back. And then they might have, for instance, a PA come in and do follow-up care or things like that, or have the primary care do the follow-up care. But yeah, there is some of that going on, and I'm not sure how to incentivize that, and it's really out of our realm, because we issue a license and then say, just go out there and do good things. We don't tell you how to do it. But I think that there are some options like that, yeah, to explore them. And like I said, that rotating practice of, okay, you have one of your people come in and they work here 2 weeks and they go home and somebody else steps in. It may not be ideal, but it sure beats a desert.
Well, orthopedics, we have our emergencies too. I mean, kids break things and whatnot. So, I mean, a lot of it we can kind of stave off in the middle of the night, take care of it in the morning and whatnot. But just something that I've been kind of stewing on is if you can get 3 or 4 docs together and, rotate in and out a week or something like that. I think that is at least something to think about if it hasn't been thought about.
Well, and as I noted, Representative McCann, Madam Chairman, I didn't mean to suggest that orthopedics doesn't have an emergencies, because I know certainly for a fact you do, but I do think that, yeah, that's going to be something that maybe our hospitals are going to want to explore. It's not cheap, if flying an airplane around ain't cheap either, and bringing a doctor in is not cheap. But if we're really trying to figure out what the options are, that may be one to consider.
Oh, questions, Representative Yin, and then Representative Clauston.
Madam Chairman, thank you. Mr. Bonenblest, I asked this 3+ years ago, but we've keep passing these abortion bans. And so do you think that the abortion bans, just perennially passing ones that threaten to put doctors in jail, affect recruiting OB doctors into the state?
Madam Chairman, Representative Yin, first I want to be really clear that there's nothing in the Medical Practice Act that relates to abortion. There's nothing in the board's rules or anything. The board is basically agnostic on that. Whatever the law is, the board follows it. So, and it would be probably imprudent of me to speculate why it is we're not getting doctors. I can show you that we've been getting an increase in numbers, but I can also show you that the number or percentage living in the state has gone down. I don't know the whys behind that. You'd have to talk to somebody who's actually recruiting. I would say that if you've got fear of being thrown in jail for what you're going to do in your practice, that might have a little bit of a chilling effect, but I just don't know that factually. So I could not tell you. You'd have to really talk to the people trying to place physicians.
Representative Clauston.
Thank you, Madam Chair. So a little interested on the interstate compact because we do it with some and not some others. You know, you've more than doubled your numbers in the recent years. How does the fee structure work? Where doctors, the fee goes to the interstate compact and the money comes back to Wyoming. Is that how it works? And then has it affected how much we charge for licenses? So just a little interest in how this could affect your board and other boards.
Be something extra in your check for asking that question. Madam Chairman, Representative Clauston, you know, it's interesting, when we designed the Interstate Physician Compact, we sort of looked at what the nurse compact was, and I'm not beating up on the nurses, but we said there's some things that are problems with it, and we perceived as medical boards. And one of them was collecting fees, because we are fee driven. We got zero tax dollars coming in. So, you know, what if we lose fees, then we lose income. So when we designed it, we said, you're still going to have to pay the same license fee in a state or similar as you would if you were coming through the normal process. That was the original premise. Because the idea is you're going to follow the same law, provide the same care, get the same reimbursement rates. You're going to pay the fee to have a license in a state. Because if you do something wrong, we're going to have all the same costs of investigating, pursuing it. So we said it is a medical license. It's not a telehealth license. But what that did, you remember I said that I thought maybe 10% of our license volume would come through that. Well, when it becomes 2/3 of your license volume, you're suddenly getting a lot more income. And so we have cut license application fees pretty dramatically, to the point where we actually charge less for the compact because we have less paperwork to do to get somebody in, because most of the vetting is done by another state and then they vouch for that licensee to us. And so what we've been able to do is reduce a lot of fees, eliminate a few fees. And last year, I hope Representative McCann remembers the physician and PA license renewal. PAs instead of $80 and physicians instead of $185 was $10. And we're right now in the middle of physician renewals, and we're charging $0 to renew a physician license in Wyoming. And it's because of the revenue we've pulled in because of that compact. And so in some ways, you know, those who are coming in are helping support, you know, the rest of the physician population. But I will tell you, I've never heard anybody complain. You know, because what they gain in so much as one day of billing in a state usually offsets the license price. So it's worked out well for us. I don't know if nursing compact is still the same way, but we very deliberately said, no, we're not going to handicap ourselves by having a compact.
Senator Scott.
I've got a question, and I'm going to ask it and hope that those come after also listen, because they may be able to answer in more detail. Seems to me in some of the areas where we are having shortages, that what's going on is that due to the high fixed costs, some of our larger hospitals are removing areas from local practice and trying to ship patients out to a hospital in, say, Colorado, where they're trying to have the potential for building a volume that will reduce the high fixed cost problem. If you do that in a particular specialty and move out their bread and butter, you'll likely move the doctor out too. And then they aren't available when there's a crisis in their particular area that you need somebody local, especially when the weather's bad. Is that a problem that we're seeing, or is that a theoretical problem that is not a real one?
Madam Chairman, Senator Scott, I don't have a lot of firsthand information on that, but I can tell you just from living in Cheyenne, I see the care leakage going south to the Front Range of Colorado all the time. And it's to the point where my wife had knee surgery done, and I didn't say anything to her, but she chose a provider in Colorado. He happened to be the team physician for the Colorado State Rams. I wasn't happy about that, but, you know, that happens. And so then obviously if they have something go south with a patient that's come down to see them and they go home to Wyoming, you're going to have some problems. And we deal with that from time to time, but generally speaking, those providers are pretty good about making sure they've got some sort of coverage. Or at least, you know, there's initial contact that can deal with sort of the first pass of the problem. But yeah, there's a lot of leakage, and perhaps Representative McCann can talk about that as well, is the orthopedic leakage is tremendous. Just because you've got Orthopedic Center of the Rockies in Fort Collins and Loveland, you've got everything in Denver. And so it's a real problem. I can't quantify it. I can't even give you real hard examples, but it's got to be there. Yeah.
And Madam Chairman, a follow-up if I may.
Follow up, Senator
Yeah,
Scott.
what I was concerned about is not so much follow-up on individual cases that have gone south and you, when they come back home to Wyoming, you need somebody to follow up. But if you have somebody whose bread and butter was a particular kind of operation and they lost that, went down to Colorado to try to build volume down there, then if there's somebody with an unrelated problem that needs that specialty on an emergency basis here, the doctor is no longer here and we could have a real problem, especially in the wintertime when we can't transport part of the time. And I'm wondering if we're getting into a problem with that.
And Madam Chairman, Senator Scott, I think we probably are getting into that. I think the other thing you find is as care gets bled off to other states, even though you may still have a volume, we don't have the same volume. And first off, you know, your fixed costs are going to be your fixed costs. But the other is you talk to a surgeon and they will almost inevitably tell you that, no, if I take 2 weeks off for a vacation, I got to get my skills kind of back up to speed. They just, kind of like I guess a golfer. I'm not a golfer, but you know, you take some time away from the game, you come back, you have to get back up to speed. Similarly, if you're not doing as many of these procedures as you really need to stay up to speed, there's also going to be an erosion of quality there with what stays in Wyoming.
Further questions, committee? Oh, Representative McCann.
Thank you, Madam Chair. Probably won't make any friends with this, but some of it's the business model that these hospitals have. We just see, I'm in Rock Springs, so I see a lot of stuff go to Salt Lake. And, you know, when the physicians are employees of the hospital, a lot of times things get sent out because they just don't want to do it. Like it or not, it's the truth. So I don't know if the business model's all that well, especially if it's in the middle of the night. A lot of that stuff gets sent down to Salt Lake. So that's at least some of it as far as the bleeding off.
Committee, any other questions, any online? I do have a
Yes, ma'am.
comment and a question. One of the things in Fremont County is there's a tendency to fly everybody out. And that could be to Natrona County, that could be to Salt Lake. And it happens, I mean, often. It's not just on occasion. So that again would be out of state. So any comments you may have on that, but also I wanted to just go back to where you were talking about foreign doctors that may come in. If we're seeing that, okay, they have to requalify to our standards, I would like to know what that looks like and also how they would then meet that criteria. And the other thing is are our medical schools more prone with Hathaway and different things like that? Are we more prone to want foreign students than local students? So the doctors wouldn't stay.
Madam Chairman, I think in answer to the last one, I have no idea what the propensity is to bring in foreign graduates or anything into any programs. And let's see, your first question was sort of about, I'm sorry, help me with the first part of it because I want to get that and then I'll talk to the foreign trained physicians.
Well, first off, I said that we fly a lot of people out of state.
Yes, ma'am.
Yes.
And that is something way above my pay grade as far as medical judgment, all those different things. That's something that I have absolutely no knowledge of and would be absolutely off the reservation saying anything about it. I just don't know. So I'd answer it if I could, but I can't.
Okay, and then to follow up with that, what about requalifying a
Yes,
foreign
ma'am.
student coming up?
And I'm glad you asked because the first time the bill came around, which was back in the last general session, it was pretty bare bones. It said, you got a license in another country, you can come practice here. And we said, well, wait a minute. There's all sorts of things like English proficiency and so on. And can we do a criminal background check? So we worked with Representative Wasserberger considerably to really put some meat to the bones on that bill. To the point when somebody comes in and they've been licensed in a foreign country and they've had equivalent medical training, but they haven't had the postgraduate, the residency training in the US, then they work in a supervised situation with a licensed physician, sort of like the PA model used to be, where there's somebody looking over their shoulder, somebody who knows how to practice in the US, in Wyoming, and they're watching them, they're mentoring them, and then they report back to the board. And then after 2 years of that, or 2.5, well, we had 2 and 3 years, depending on what it was, but then at that point, then they can be eligible for a full unrestricted. In the meantime, they're on a limited license, but they have to be working under that supervision so that there's somebody who's, they can't just bring them in, dump them down and say, start writing scripts, have a good time. That's not going to work the way the bill's been crafted or recrafted. So there's maybe some refinement still, but that's what we're seeing across the country is that's the model most states are picking up.
Thank you.
Mhm.
Senator Hutchings.
Thank you, Madam Chair. I believe the presenter hit on something I think really important, and that is you may have a doctor here in Wyoming who has done, I'm going to use the total knee replacement because I just had one. He may do one once a month, once a week, whatever, but I went down to Colorado and my doctor does 8 or 9 a day on his surgery days, and they're very efficient. I've had 2 and I like what he's done. So maybe that's something too to think about is we can bring them in, but if they're not really practicing, like he said, the golfer, their skills, their profession, then they're going to get a little lax and maybe not do things as well as they should, where you can go down to Colorado, maybe Salt Lake, Billings, wherever, and you're dealing with a well-oiled machine. So just a thought that I thought he brought out that it could be very important. The more you do, the better you get. So you want to be somewhere where you can practice your craft as much as possible. Thank you.
Thank you. Any other questions from the committee? Okay, thank you very much.
Thank you for hearing me out.
Appreciate it.
I'll go sit down, but if you need something, throw something at me and I'll answer.
Okay, thank you. Okay, yes, go ahead. If you just introduce yourself and.
Absolutely. Madam Chairman, members of the committee, my name is Rachel Philbrandt. I'm the Executive Director for the Board of Nursing. Similar to as Kevin said, I do not have many slides for you. I'm here to answer any questions you may have in regards to nursing. I did provide some specific numbers regarding licensing here in Wyoming. I do want to mention we license, discipline, and regulate certified nursing assistants, LPNs, RNs, and advanced practice registered nurses. APRNs in Wyoming have full practice authority and are not required by the Board of Nursing to have physician oversight or collaborative agreements in place. However, facilities may be requiring that outside of the Board of Nursing. In Wyoming, as you can see by the numbers provided, and this was as of April 27th, we have 833 APRNs with a home address in Wyoming and 3,226 APRNs total. Again, these are home addresses in Wyoming. this may not be where they're practicing, but this is where they're residing. We do request that all licensees update their addresses every 2 years with renewal or within 30 days of moving if they remember to do so. In regards to specifically to certified nurse midwives, they are part of the advanced practice registered nurses and do have full practice authority here in Wyoming. There are 55 in Wyoming and 19 licensed with a home address. On the second page of that, you'll see where those certified nurse midwives are residing. Similar to what was discussed about certified nurse midwives, because it's on the topic, and if you don't want me to stay up here multiple times, I'll just speak to it now, is psychiatric mental health nurse practitioners are also part of that advanced practice registered nurse. And in Wyoming, we've licensed 448 with 124 of those with home addresses here in Wyoming. Earlier today, I heard comment in regards to keeping our students here in Wyoming when they graduate. And we started recognizing this statistic a couple years ago, and we just, in 2025, presented it to our board in January. 84% of the registered nurse graduates in Wyoming became licensed in Wyoming. I don't know if that means they're still working here, because we don't do renewals. We do renewals every 2 years, so they'll renew this year. But I do think that's a pretty good number for us here in Wyoming, that 84% of those have stayed. And I'll stand for any questions.
I do not see any questions, but
right.
thank you very much for all
Thank you.
that. And it's a very positive note. Good,
Thank you.
good. Oh, just a moment. Yes, Senator
Thank you,
Brennan.
Madam Chairman, and I apologize that I was a little late to asking this. And I feel silly asking this because I feel like I should know the answer, but I don't. I'm not 100% sure, so I'm going to ask. APRNs, are they part of the estate compact? Is that part of?
Madam
Nurse.
Chairman, Co-Chairman, thank you so much for asking that. APRNs are not part of the nurse licensure compact. The nurse licensure compact only includes the LPNs and RNs. There is an APRN compact per se. Currently, there are 4 states that have it enacted, and I will tell you at this moment, it is being looked at a national level to be further clarified to provide more broadness for licensure. There's been some hiccups in regards to the current APRN compact, and until that is enacted with 7 states, it would not go into effect, and there's been multiple problems with that. One of the problems throughout the nation is APRNs do not have full practice authority throughout the nation, and in addition, they don't always have prescriptive authority. So that changes things a little bit. The current APRN compact requires 2,080 practice hours before you're eligible for the compact. It doesn't mean that you have to have oversight or anything of that sort. It means if you were to graduate today and be licensed in Wyoming, you'd have to work approximately 2,080 hours before you'd be eligible to work in a compact. And that has provided some concerns in other states, even in Wyoming. So at this time, at a national level, it's being re-looked at for the APRN compact to try to see what can be done to more mimic the RN and LPN nurse licensure compact.
Thank you. Follow-up? No follow-ups. I appreciate it. I'm glad that I asked that question, actually.
Thank you.
Okay, thank you.
Thank you.
Madam Chairman, committee members, thank you. My name is Marie Adams. I'm here today as a board member. I'm also an independently practicing licensed midwife. in the state.
Good afternoon, Madam Chairman and committee members. I am Carlos Gomez from ANI and the Professional Licensing Boards, and I serve as the Executive Director for the Board of Midwifery.
Okay, if you're ready, please give your presentation.
Well, I'll just give you a brief introduction to what a certified professional midwife is. We are specialists in normal physiological pregnancy, birth, and postpartum. And our scope of practice is like the 9 months of pregnancy, the labor and delivery, and then 6 weeks up to a year now for postpartum. And again, we are experts in physiological birth. And so really our guide, we provide like the guardrails, and we just inform and educate our clients and provide counseling and support just to let them know, hey, you're everything that's going on with you is normal. Carry on. Or we say, you are veering into territory that is not normal. Let's try some things to see if we can get you back to being normal. And if not, then we really need to seek care at a hospital or with a physician. Are there any questions?
Committee, any questions? And I'm sorry, did you say Mrs. Adams?
Yes.
Yes. Okay. I have one, as board member, and then you're saying you work with the clients aren't necessarily the midwives, or are they?
Well, yes, because I'm on the board as a practicing midwife. Our board requires, I think, a physician and a number of midwives and a certified nurse midwife, and then a member of the public. So
Thank
I'm
you.
one of those midwives
Well, thank you for
on
your
the
work.
board. Well, thank you.
Yes, sir.
Madam Chairman, members of the committee, just a few, I guess, tidbits of information. Some of it sort of gathered from some of the other conversations that were happening. Currently, there are 26 certified midwives in the state of Wyoming. I couldn't give you an exact number, but I can say about 40% are in-state, residing in-state, with the current number at 60% that reside out of state. I couldn't necessarily tell you which states that is, though anecdotally I do know, some are from like Colorado and such. Another piece of information, if I may add, in 2024, just looking at the vital statistics, there were 202 home births in the state of Wyoming. Thank you.
Any questions? Okay, I don't see any. Just to say thank you so much. This is definitely a place that we need to be, especially in the rural communities. And I know a lot of women are going back to the more natural. And so thank you for your work. Do you see that this trend is going to increase? And do you have any comments about how that could happen?
Is that a question for the board? It does seem like it's in Wyoming, I'd say it's pretty stable. We attend like less than 1% of births in the state. I live in Evanston, so I also work at a birth center in Ogden, Utah. And Utah is a different landscape. And I think Utah has one of the highest rates of home births in the country, but they're about 5% of all births are at home in Utah. And they have pretty favorable policies in Utah. So.
Thank you. Did you have any more comments?
Thank you, Madam Chairman. I do not.
Okay. Well, I want to thank you both for coming today and thank you for waiting till after
Madam
lunch. We
Chair?
appreciate that.
Madam
Oh,
Chair.
Senator Hutchings, I apologize.
Oh, no, I know I'm up here and it's kind of hard to pay attention. I did want to just dig in a little deeper. Both the presenters seem a little shy, but what they do, I think, is very important. I have a friend going through a midwife now, and I think it's important that she was told, hey, your iron's down, and if you don't get your iron up, then we can't do a home birth for you, or the midwife can't assist you. You'll have to go to the hospital. So the precautions that seem to be taken are important, and I don't want these two to just come in, give us a little presentation and go away thinking, did we really make an impact? But like I say, I think what you're doing is important. And can you elaborate on your strengths? Like, are you having problems with any of these home births? Let's say you do 10, are 9 out of 10 awesome, and then there's just that one that just, we shouldn't have done this one. Kind of give me a feel for how the midwives are doing here in Wyoming, quickly, if you could.
Madam Chairman, Senator Hutchings, thank you. I can speak to that. I have to take off my board member hat and put on my practicing midwife hat. Yeah, I would say when you do 10 births, well, let's do 100. And out of those 100, 85% of the time, the client does not need any help. She can just have the baby, the baby just comes out by itself practically. And then I would say 5% of the time, it's like, wow, I'm really glad I was here and could kind of get you over that sticky spot, or suggest to you that, you might like getting into this position, or maybe you want to get out of the pool now. And then 10% of the time, this is a situation where we really, we need a higher level of care. You probably need to get to the hospital. And the another 5% of the time is like, yes, you really, this was a life and death situation, and it was either something I did or something that the hospital did that saved you or your baby. So most births are very straightforward. Some of them need a little help here and there. And then some are truly, you really do need a cesarean or life-saving care. So does that answer your question, Senator?
Yes, it does. Thank you so much.
Thank you. Thank you. Thank you, Senator Hutchings.
Yes, thank
Madam
you.
Chairman.
Representative Clouston.
Thank you, Madam Chair. Thank you. You had mentioned that in Utah, there's more births at home because they have some more favorable policies. Can you tell us maybe what some of those policies are that you see are different?
Well, in Utah, Utah's a kind of a strange state because you can have a license, but you don't have to have a license. And part of it too is just this Mormon pioneer culture where they've always had midwives. But in Utah, if you have a license, similar to Wyoming, licensed midwives are not allowed to attend breaches or twins, but licensed midwives are allowed to carry like anti-hemorrhagic medications and oxygen. And if you're not licensed, then it's, like I said, you don't have to have a license. And if you don't have a license, you can't carry any medications, you can't carry oxygen, but it's just, buyer beware. Whoever, if you want to call yourself the breech expert, someone, you can attend breaches, twins, and it's pretty much buyer beware, but there's no requirement for a license or any of those rules and regs. So now that being said, I do know a number of unlicensed midwives in Utah who still kind of on the side will carry Pitocin and Methergin, because one of them has said to me, I would rather go to jail than to a funeral, so I'm going to carry these life-saving meds. So, but yeah, so. Thank you, Representative. Thank you, Madam Chairman.
Yes, Representative Yin.
Madam Chairman, thank you. Sorry, remind me your name again?
Marie Adams.
Maria, Ms. Adams. So you were telling me that you operate out of Evanston. I did remember hearing last year that there was going to be a birth center opening there. Is that correct?
Yes, and I work with the midwife who opened that, yes.
Great to hear that. I'm curious, do midwives have a trade organization that would be willing to work with us, or do most midwives just operate independently? Because I think
Representative Yen, Madam Chairman, thank you. Yes, there is, but it was kind of defunct now. There is like a Wyoming midwives organization, and like we have a Facebook page, but I think we only ever go onto that when it's time to like recertify for newborn resuscitation or see, and then we, bring in someone who can run the workshop, and then everyone kind of gets together on the page, and we might talk about this or that policy that might be coming down the pike, things like that. There is a national organization that I think some of us belong to. I don't think there's like an official dues paying state midwifery
so,
organization.
Madam Chairman,
Representative.
thank you. Ms. Adams, I think the board, this committee clearly wants to hear from midwives, but I think it'd be appreciative if you guys could speak as one voice. You're just one board member on the board, which is different than, a trade organization speaking to us on what policies they'd like. I think we want to hear what kind of policies would help have natural births in Wyoming. I think there are plenty of people on the committee that are interested in making sure that uncomplicated births have access to care. And so I think one thing I would ask from you is to reach out to other midwives and ask, please participate in these hearings, because we do want to hear from you.
Madam Chairman, Representative Yin, thank you
Yes,
very much.
yes.
I will reach out to the other midwives and say, this is what's going on, and they want to hear from us. So what do we want to bring to you? What would you want to know from us? What are you expecting us to come back with? Anything?
Mrs. Adams and Representative.
Madam Chairman, I think Representative Clausen was just saying, what are the positive policies that other states have, right? And so I think we're all interested in how do we make sure that moms can have healthy births in the state of Wyoming, and if there are positive policies that midwives think that they can bring to us, we would want to hear them.
Representative Yuen, thank you. Madam Chairman, thank you.
Thank you.
I will
And we-
reach out. There aren't that many of us that live in the state, so.
Mrs. Adamson, and would you please give me your name again?
It's Carlos Gomez.
Carlos Gomez.
Yeah.
Okay.
Yes, Madam Chair.
What I would like to know is, looking down through here, there's licensure requirements, and there, last year, I believe in our committee meetings and things like that, or the year before, we were looking at what kind of licensures there should be or training. And here I'm seeing that there's University of Colorado midwives in Utah, University of Utah College of Nursing, midwifery program, and Montana State University. Do you know, are those all primarily united in what they believe that the requirement should be for midwifery certification, or do we need to update it, or
Madam Chairman, I believe those schools might be like nursing schools that train certified nurse midwives. And there is a difference because CPMs, certified professional midwives, we receive our nursing skills training like concurrent with our midwifery training in like what's normal and what's physiological. Whereas a certified nurse midwife is an advanced nursing degree, and you are a registered nurse first, and then I think they might require, and our Board of Nursing would be able to speak to this better. But I think most of them have a bachelor's in nursing, and then they go on to it with advanced training to midwifery training on top of their nursing care.
Thank you. And not to go back to a Little House on the Prairie or anything like that, but just to say, I had it in my head that midwifery was pretty much a person would come to my home and we would do that. But I'm hearing through conversation that there's facilities, like almost like an office that women go to have these services, or is that wrong?
Well, a lot of birth centers will have like prenatal rooms attached where we just like do the prenatal care and the postpartum care. So you come in for your like regular postpartum visit, and then we do the birth at your home. So, or we can do if it's a birth center, we have a room for a delivery too.
Okay, thank you. Mr. Gomez.
Thank you, Madam Chairwoman. One of the things, I guess, to go back to your question about sort of the education piece, in statute, it does reference the Midwifery Education Accreditation Council, and that's one of, it's sort of like a guideline when it comes to the education piece for the board, and that's written into statute.
Okay, any other questions or comments? Thank you for, Board of Nursing.
Yes, Madam Chairman, I would like to clarify for the certified nurse midwife, which is an advanced practice registered nurse, they must have a doctorate or master's degree in nursing and have completed an advanced program of study in a specialty area and then taken and passed that national certification. Hopefully that provides clarity there.
Yes, and thank you. And not just for this board, because I know that we're all very pro, or it seems to be very pro for this type of work, but also for those online, that they would know what the possibilities here in Wyoming are, or what they could be for them in the future, either as a client or a professional. So thank you very much.
Thank you.
Are there any other stakeholders or comments anywhere online? Ms. Talbot? No? Okay, anything else? Okay, next, pardon me? Oh, yes, I thought I said that. Public comment. Oh, yes. Good afternoon. Please introduce yourself.
Good afternoon. Thank you, Madam Chairman and members of the committee. My name is Britt Borrell. I am Executive Director for WYO United, and we are a nonpartisan organization that is focused on advocating for reproductive freedom and also expanding access to reproductive care in Wyoming. Our maternal care crisis has been nominally prioritized by this committee for years now. However, since the fall of Roe, this committee seems to have actually prioritized stripping freedoms from its constituents via unconstitutional abortion bans.
Please give your testimony, but
This is my testimony, though. I think that the abortion bans have actually really made it difficult for us to recruit providers.
descending.
Okay. That was not my intention. So unconstitutional abortion bans create a muddy regulatory system for providers to navigate, and it actually exacerbates our maternal care crisis further. Since 2022, we have seen 4 labor and delivery centers close at our rural hospitals, largely attributable to provider shortages and the refusal of our legislature to increase Medicaid reimbursement rates to align better with costs. I was pleased to see those rate increases approved in the budget earlier this year. Half of our counties do not have a practicing OBGYN, and here in Casper, one of the largest population centers in the state, we only have 2 OBGYNs. The wait lists are difficult to navigate for those needing immediate care, and many of our expectant moms are forced to travel to Douglas, which can be treacherous in the winter. Wyoming is not alone in this maternity care crisis. OBGYNs are in short supply across the country. However, when we continue to press forward with unconstitutional abortion bans that taxpayers are forced to defend in court, it creates a legal morass that makes our recruiting challenges even more difficult. Why would qualified providers want to practice in Wyoming when they are threatened with criminal charges, jail time, and revocation of their licenses just for providing the full standard of care to their patients? And we have seen in states like Idaho, for instance, after they passed one of the most severe abortion bans in the country, they've lost over 1/3 of their practicing OBGYNs there. The full standard of care has and will always include abortion. And the latest unconstitutional abortion ban that was rushed through this last budget session did not even have the decency to pretend to be humane. It had no exceptions for rape or incest, no exceptions for fatal fetal anomalies, many of which are discovered at the 20-week scan. Policies that could actually help Wyoming families would be repealing the sunset for HEA 84, as was mentioned by the Wyoming Department of Health, supporting Title X family planning clinics, improving access to affordable childcare, and feeding hungry kids in the summer. In other words, making Wyoming a hospitable place for families to grow and for providers to practice. I would also ask that you stop wasting taxpayer time and money by attacking our bodily autonomy. Thank you.
Thank you. Any questions or comments? Okay, thank you for coming today. Mr. Schriftman, please introduce and give us your testimony.
Thank you, Madam Chairwoman. My name is Ross Schriftman, citizen living in Casper. I am also a licensed insurance agent since 1975, specializing in health insurance products. And for the last 35 years, I've volunteered working with members of Congress and legislatures for healthcare reform. The challenge that we face, not only for maternity care, but healthcare in general, much of it has to do with finances. The 2 elements that I want to talk about is the rising cost of health insurance and the low reimbursement for providers. So in 2010, Congress passed it was called the Patients Protection and Affordable Care Act, otherwise known as Obamacare. It was effective in 2013. As an insurance agent, I saw rates skyrocket. Now, it's not the legislature's responsibility to reform that law, but I would encourage members of the legislature and the citizens to talk to our congressional delegation and allow Wyomingites to purchase the kind of insurance that they want and need, and expand health savings accounts as well, and promote various things that are going on with various options for small businesses in Wyoming. So for instance, there's something called association health plans. There's a lot of people that are not insured in Wyoming, and if they work for a small ranch or a farm, it's hard to get insurance. The other element of this is reimbursement. As it was mentioned from the Department of Health, about 30% of maternity coverage is in Medicaid. And on page 21, it showed that the payment by Medicaid is about $7,500. That's going up by some of the things that the legislature has done. But the true cost is about $20,000. Private insurance plans pay close to, not always, but close to the 20,000 level. So that's important. From the providers that I've listened to today, it's important that we allow them to have as much flexibility to serve the communities as possible. And options, as just mentioned, midwives, doulos, and birthing centers are very important. It can be an option for us. I understand that we do not have a neonatal intensive care organization here in Wyoming. I know people, women that have gone down to Denver to have a preemie baby, and it's logistic and difficult for the family, especially if they have other kids. So we'd like to see what we can do about that. I know that's a big challenge. The other thing is I just saw this past week, the federal government now has a website called moms.gov, and it's resources, information, and help for new and expecting mothers. It has information about resources in the community, federally qualified health centers, nutrition, and many other services that are mentioned. Pregnancy is a natural occurrence in humanity. We've had it, always had it. It is very well known that a mother will provide benefits to her child in the womb, but also the baby provides benefits for the mother. There was a study done a few years ago of elite female marathon runners. The majority of them ran faster after they had their first baby. Now, I'm not recommending anybody run a marathon and have a baby, but it is healthy, and the nutrition and the natural process needs to be supported. And I'm available for any questions that you may have.
Any questions from the committee? Senator Scott.
Madam Chairman, in your experience as an insurance agent, Medicaid is paying a little more than a third of what private pay is for maternity care. If we were to cut back on the eligibility in the Medicaid program in that area, would we send people from Medicaid to private pay? They would be able to pay and thus improve our maternity compensation for the providers, or would we just simply have people that are uninsured?
Madam Chairwoman, Senator Scott, we wouldn't do that. What we need to do first is make sure that the private market that's been around for a long time has the options for people to get private insurance at an affordable rate. The Affordable Care Act was supposed to lower the cost. And here we are 12, 13 years later, and it was supposed to fix healthcare too. So I wouldn't suggest that you cut off or lower what you're doing with Medicaid right now. I would say, let's improve the private sector and let's encourage people and help people get the private coverage that they need. And that way, those who are at the lower end of income would still be able to get help from Medicaid. But the more we get Medicaid payment at a lower rate, the less likelihood we're going to be able to get the providers, because the reimbursements are just too low, especially in the rural areas where you're not getting a lot of patients.
Thank you, Mr. Schriftman. Okay, is there anyone else?
Thank you.
Okay, we have some. And just to say, we're quite a bit over. If there's something that's already been said, please limit that. And we want to hear what you have to say, but please keep it. Yes, thank you. Please introduce yourselves and
Good afternoon, committee and Chairman Ottman. My name is Jen Davis. I'm with the Wyoming Primary Care Association. I will keep my statements brief today, but I do just want to share a little bit of information on some work that's actually happening around the state. As you all are probably aware, this is I think the 4th year of this topic in this committee. And so there's been a lot of work around this topic and a lot of recommendations that came out that have actually been absorbed through the private sector and through some of our nonprofits in the state. And I think that really deserves to be elevated because there's been a lot of thought that's gone into listening to recommendations that came out of the past and has gone forward. So one of the examples is we have now the ECHO series for emergency obstetrics, which is hosted through the University of Wyoming, and it is targeted at really building capacity within our networks of L&D providers, whether that be a midwife, whether that be an FMOB, whether that be an OBGYN, looks at labor and delivery nurses, looks at emergency room staff. So it is targeting a wide network of providers doing labor and delivery in our state, whether they have that service in their hospital or not. Women still show up in the ER and they need to know what to do and how to do it and do it well to the best of their ability, either to deliver the baby or to triage and get that baby and mom to a higher level of care. So that ECHO series is now in its 5th month. As of now, it's been going for 5 months. And it has had really great attendance. It still has a lot of growing room to go. But there is opportunity now to really help us build capacity and do training for individuals. Because one thing that we know, and I'm sure you'll hear from some of the hospitals here, it's not just about money why these hospitals aren't doing labor and delivery. It's a matter of safety for women when that volume is so low. And I think the discussion about orthopedic surgery earlier was a great segue into that. You go to someone who's done a lot of them. Well, you also want somebody who knows what they're doing delivering your baby. It's a really critical thing. And so if you're only delivering, a handful of babies within a hospital a year, those providers aren't able to keep their skills current. And so either we need to find a way to pay for them to keep their skills current by sending them somewhere else to do that and cover the cost of that, cover the cost for the hospitals to have those people out, or we need to find another solution because it's not safe for them to deliver really low volumes, as well as the cost, as you heard earlier, for paying for an OBGYN, which, is probably close to $500,000. And if you're getting a reimbursement of $7,500 from Medicaid for a third of those, it's going to take you a really long time to pay for that doctor to be there. So this is so complicated and so multifactorial. And there are efforts that are going that we have started to try to do something to move this needle because this is a critical thing and we can't just keep waiting and keep having conversation. We need to do something because there are women dying. Wyoming is number 28 out of 50 in the latest data on maternal mortality. We need to do better. And this is the time that we need to do something. The other thing that I want to share is Wyoming has a maternal mortality review committee, and then there is a maternal mortality prevention work group that looks at the recommendations that come out of the maternal mortality. The number one reason for maternal mortality in Wyoming, and has now become the number one in the nation, is substance use and behavioral health. Those things we can do better and prevent. Number 3 is postpartum hemorrhage. We can train people around postpartum hemorrhage. We can work with people to get care. The postpartum coverage that Deputy Director Fuchs talked about earlier is critical. Most of the deaths are occurring now between day 43 to day 365 postpartum. So again, we need to make sure if we want to save lives that we are investing where it's necessary and that we're doing the thing to keep these services at a high quality level because women and babies deserve that. And we also need to look at this when we talk about maternal health and labor and delivery. it's not just about women. It's about now you have an infant there and you need care for that infant. So it's not just now we've got to care for mom postpartum. Now you have a little infant there, and maybe it's a preterm infant. And as mentioned earlier, we don't have a high-level NICU in Wyoming. Those need to be flown out. And we need to be training the providers here, whether it's in our ERs, whether it's our FMRBs, our OBGYNs, our midwives, to recognize that and know when to triage and move patients, because that's how you avoid death and injury. So I think that as we look at the ECHO series, there's an opportunity to really build on that and continue to help support capacity of the providers that we do have in the state. And then the other thing is there is training being offered around the state that is targeted at community development for emergency delivery of infants. And that is also being funded through our organization, through the Primary Care Association, as well as through the Department of Health, of helping getting that training across the state so people know what to do. And the Prevention Committee just met the last 2 days here in Casper and are coming up with recommendations to address some of our mortality issue here in Wyoming. But we have a lot more to do in that space. The last thing I just want to leave you with, and this conversation happened a little bit earlier when Mr. Fuchs was up here, was the discussion around home visiting. That came out in the meeting in the last couple of days with the maternal mortality review. Just wanted to be clear, there are other options for home visiting in the state beyond the public health nursing program. There is the Parents as Teachers program that is funded through the federal funding of McVie. And they shared some numbers of what they're serving. They're currently in 7 counties: Albany, Campbell, Carbon, Fremont, Laramie, Natrona, and Sweetwater, soon to be opening in Hot Springs. In the last fiscal year, they served 289 households with 349 children. 125 of those were Medicaid. So it goes to what Senator Scott was discussing about, are those on Medicaid getting home visiting? So there is another catch point. If the public health nursing isn't catching them, then we have 125 of them that were caught by the other program in the state. So those are just some things that we need to think about as we talk about this topic. We've got to look at it systemically. And that's what I ask, is that I really think we need to dig into this with a group of experts, and we need to do something. Like, let's do something instead of just continuing to have this as an interim topic with little movement on it. That's all. I'll stand for any questions.
Thank you, Ms. Davis. One thing I was notified here is the building locks at 5 p.m. So if you plan to testify, anybody, anywhere that's planning to come in and testify after 5, please be here before 5, or you will not be able to get into the building. So thank you for that. And right after your testimony, we're going to take a little break. And so thank you. Any questions for Ms. Davis? Representative Yin.
Madam Chairman, thank you, Ms. Davis. Are those, I'm trying to remember because I was here for those recommendations. Are they online somewhere? Is there, how can we look at them so we can see if we want to bring them up again?
Chairman Ottman, Representative Yen. I believe so. I think they were in materials that we had a couple of years ago in this committee that came out of the Governor's Health Task Force OB subcommittee. So I do believe they should still be in historical documents on there. If not, I can find it and I can send it back to the committee so that you have that.
Senator Brennan. Okay, thank you. Any other questions? Representative Thayer.
Thank you, Madam Chairman. So I want to thank everybody for the comments, been sitting here quietly, doing a lot of thinking. Again, I want to thank LSO, staff, Anna and Clayton for putting together all these amazing documents on strategies and everything. And Jen Davis, thank you for your comments. I definitely would like to see those recommendations and reports also from the last few years. Thank you.
Okay, anyone else? And just to follow up with that, I know there's a great frustration in many areas about, okay, when are we going to do something? And as we look at the boxes of materials that we've gotten over the years, and we're in session 20 days, and there might be a bill, it takes all of these reports to get together so that we can all come to a consensus. And that's not always easy, as you know. So thank you for all your work. And I think we're getting more and more aware of some possibilities, but strategies would be good. So if you could send us over some, that we'd appreciate it.
Chairman Ottman, I'm happy to get you those documents. And just a comment to that, I do appreciate this is very, very complicated topic. And I do think that, maybe something to come out of this committee is a targeted work group with experts around the table who do have more than 20 days to dedicate it to it, because it does need ongoing effort. And your guys' time is limited. You're volunteers here as you're public servants, but you also have other jobs. And so there is a lot of expertise in this room around the state that I think with a collaborative partnership between the agencies, the legislature, and the public experts, we could really move the needle.
Thank you. Okay. Next, are you two together? Are you sure? I'm sorry. I'm sorry, I missed that. What did you say? I'm a friend. Oh, okay. Oh. That's on record. It's okay. Yes, please excuse me. Did you have a question? Okay. Okay, please.
Madam Chair, members of the committee, thank you for your time today. My name is Lance Porter. I'm the CEO of Banner Wyoming Medical Center, and I wanted to get up today and talk about some of the challenges as a hospital operator that we have in OB today. I've been a CEO for 13 years. 7 of those were in a critical access hospital. So I have recruited OBGYNs to both rural communities as well as a rural yet high level of care like Casper. And so as I've done that over the years, there's a few things I think that are absolutely critical in bringing more OBGYNs to our community. The first one is livability. And there's sometimes not a lot we can do about that, whether you're out in the middle of Wyoming or you're in a larger organization or a larger town like Casper or Cheyenne. We can invest in our communities, but there's also that spouse. We have lost countless candidates because we didn't have jobs for the spouse and amenities for family members. That is a real challenge. We are competing for candidates with every other state in the country. I can't tell you how many times I've sat down with a candidate and they said, thanks for your time. I'm now off to interviews in Colorado, Utah, and Nevada. But we'll get back to you if we decide on you. The other thing that's very important is support for those candidates. One of the biggest aspects of support is what we call burden. And that is the amount of time that you're expected to be on call. In a critical access hospital in a small community, the last one I led, we had 2 OBs. We were fortunate to find OBs that were willing to be on call every other night. That means they had to be within a half an hour of the hospital and they couldn't have a glass of wine for dinner. And that is a high level of burden. And both of those OBs are no longer in that community. And so as has been said before, to have at least 3 is nice. But as was said before, that fixed cost is very, very high to have 3 OBs. If you're in a community somewhere in Wyoming where you're doing 30 to 50 deliveries, that's not a lot either to split between 3 providers. And so it's a balance of competencies, a balance of that call burden that is very, very real. And so it's something that we work with. At Wyoming Medical Center, we've helped out with bringing in some locums on weekends and holidays to help stop burnout, cover some holidays. We spend a little over $3 million a year in establishing a night laborist program, which means at nights we have other OBs that are covering the nights so that our local independent OBs don't have to work a hard day in the clinic and then be up all night and get a call to come in and then be expected to be in the OR or their clinics again. That's very expensive, and very few hospitals in the state of Wyoming can afford something like that. Very few can afford to bring in a locums that can help with weekends and holidays and things like that to put off that burnout. But we've been able to do that. We also, it's been said a couple of times that we only have 2 OBs providers delivering here in this community, and that's not completely accurate. We also have Wyoming Family Practice, which are FPOBs who also have a fellowship in doing C-sections. So highly trained. They're also accepting patients. They also do deliveries and surgeries at our hospital. But if you have an FPOB in a rural community that hasn't done the fellowship, they also have to have OB backup in the event that this turns to a C-section. So again, just putting an FPOB in a rural community requires a connection to an OBGYN that they can turn to when they have a complicated patient. So that adds to the level of complexity for our rural partners. And then, of course, we talked a little bit about specialty support. We do a lot of high-risk deliveries. We do early deliveries, premature babies. But Wyoming just doesn't have the patient population to bring in a lot of pediatric or neonatal specialists. We rely a lot on children's or university level medicine who are good partners, but we do preemies here. We do, and I'll let my colleague here who's a physician talk to that and what we can, we can't do. And in conclusion, I'd just like to respond to Senator Scott, if you don't mind. You had a question about whether or not larger hospitals transfer to other hospitals within their system. And I can give you a definitive answer that no, we do not. Our hospital in Greeley is the other large hospital in our Western Division. It's the same level of care with one exception, and that is advanced surgical oncology. They are affiliated with MD Anderson, which is a nationally recognized cancer program. And so we will occasionally, when our own surgeons can't handle an oncology patient, we will transfer there. Otherwise, if we transfer, it's for a higher level of care usually found at a university medical center, level 1 trauma center, and such. Our reason for being is to keep Wyoming patients in Wyoming. And I can talk to you more later about the programs, the physicians we brought here in order to do that. But if you talk about other hospitals, a lot's about how close they are to Billings, how close they are to Colorado, to Utah, those kind of things. But we have worked over the last 5.5 years to keep Wyoming patients in Wyoming because that's better for everybody. Thank you.
Thank you. Okay, yes, ma'am.
Hi, I'm Dr. Susan Sheridan. I'm an OBGYN here in Casper, Wyoming. I am a private practice physician and a small business owner. I do not work for, but rather with Banner Wyoming Medical Center. A couple of things that I wanted to discuss. We're spending a lot of time today talking about expanding service and privileges and scope of practice of various mid-level providers, including certified midwives that are non-nurse midwives, pharmacists, advanced practicing physicians or providers. It's important to recognize that one of the biggest obstacles as a specialist provider in the state is covering people that are not trained to the same level that you're trained. So I'm the backstop. When something bad happens with a nurse midwife that's providing care to a patient, that patient gets brought to me. And I'm in it regardless of what happened before that patient came to me. I do not have tort reform. There is no tort reform for me. My personal assets are at risk. My medical malpractice is expensive. My medical malpractice has a cap on it for what my malpractice carrier will pay out in a major lawsuit. So it is a major barrier for me to be covering providers that I feel are not adequately trained to be doing the scope of practice that they're doing. And that is a major barrier to recruiting physicians to this state as well. I routinely have to put things in my husband's name so that to try to take them out of my personal assets in the event that I were to get sued for anything, whether it's my doing or whether I'm stepping into a bad situation to begin with and trying to make a better outcome. So it's really important when we recognize scope of practice that we look very closely at what the training requirements are for those scopes of practice. I would be interested to hear more in depth on what a certified midwife goes through for training compared to a certified nurse midwife. I know what a certified nurse midwife goes through for training, and I know what their scope of limitations are for them as a group. I don't know what the scope of training is for certified midwives. I have an idea, and I don't think it's the same standard. So I find it somewhat interesting as a provider in this state. I've been practicing here for 18 years. That we're talking about trying to bridge care gaps with providers that have less training than what we'd ideally like for ourselves. You're wanting to provide care gaps, and yet you're going out of state for your own care and for your family's care. You're going out of state for your knee replacement, while you talk about providing care to other members of the state with less qualified providers. The gap needs to be bridged to figure out how we can get providers in this state and to keep providers in this state. The WWAMI program provides a good pipeline for providers coming into the state of Wyoming. The WWAMI program has about 60% return rate for the 20 students a year that they educate. But for those students, there's about 48 applicants a year to the WWAMI program. Only 20 students per year get accepted. That means there's probably 28 other Wyoming residents going to medical school outside of the WWAMI program. And yet there's nothing to try to entice those people to come back to Wyoming. If we can only train 20 students a year and there's 48 per year on average applying, what can the state do to subsidize those people that are going to medical school outside of the state of Wyoming because they couldn't get into the WWAMI program? How are we helping them with student loan repayments and subsidizing some of their medical education as an incentive for them to come back to Wyoming?
I want to thank you for that because it's always good to hear the other side or concerns. One of the things I know from last session was we are looking at the University, I believe, of Utah to see about possibly a relationship there.
Mm-hmm.
But thank you, and I can see your frustration. So whenever we're at risk, it's tough. Yeah.
I think that's one of the biggest limitations to recruiting is not feeling like you're, as a physician, that you're supported and that you're hanging yourself out to risk every day.
Yes. Well, okay. Senator Brennan.
Thank you, Madam Chairman, and Dr. Sheridan, right? Correct? Thank you for being here and for your testimony. I appreciate it. If I put the pieces together, right, you're one of 2 OBs here in Casper, is that correct?
Correct. As of a year and a half ago, there were 6 of us. There are now 2 of us.
That is a lot more call and a lot more years. I want to thank you I think you brought up a couple of really important pieces. One of them being that our physicians in the state, that your personal assets are on the line due to our laws and our tort reform laws. And I think that is a big issue in the state and with just physicians and malpractice and that. And so I want to thank you for bringing that up as something that I think that our committee might hopefully look at. And then also just bringing up the number of students that go to medical school outside of the WWAMI, and is there a way to bring those students back to Wyoming? So thank you very much.
Madam Chairman.
Any questions? Senator Scott.
Madam Chair, am I right in understanding your testimony that the tort issue is a major obstacle to recruiting here?
Absolutely is, Madam Chairman. Senator Scott, yes, it absolutely is. Our malpractice insurance rates are significantly higher than states that have tort reform, over double. And the burden of risk that you take on in a state without tort reform, or a state, for instance, like Montana, that has a state medical board that has, in order to bring a lawsuit against a physician, you have to deem it worthy through this board. Those states have lower malpractice rates and they have higher physician retention rates.
Thank you. Representative Clauston.
And thank you to the panel. I want to bring up, this is my 4th summer on this committee interim, and we talk about this every time. It's important. As far as Wyoming, it's a wonderful program. We're going to hear about WICHE. So students that don't get into Wyoming can also do WICHE. So we have implemented that for those students. You know, we increased the postpartum care to 12 months. That's something this committee's done. And then we also, if I did my table napkin math correctly, Medicaid births will probably go from $7,500 a birth, total reimbursement to about $13,000, which is a significant increase. So I guess what I would really appreciate too from the 3 of you or anybody else in the room, if you have some other ideas on things that we can do to improve, I heard tort reform. I think we would all appreciate that. You know, this is a problem that the governor's task force, we've worked on for a long time, and it's going to take a state level. And I really appreciate all of you taking your time today to help us work through this issue. Thank you.
Madam Chairman.
Yes, Ms.
Representative
Sheridan.
Faustin. I think in working very closely with Banner Wyoming Medical Center, transitioning from Wyoming Medical Center county-owned hospital to Banner Wyoming Medical Center, and working through some of the surrounding regional issues, I think that the idea of regionalized care that somebody brought up earlier in this meeting is really interesting. We have recently interacted in a different way with Memorial Hospital of Converse County, where they have, you know, their own OBGYNs, and they now have a hospital in Casper where they're providing care. They are providing obstetric care in a hospital that's 35 minutes from here, 35 miles from here. They do not do deliveries under 36 weeks in that hospital. We do deliveries 34 weeks and above here. If there's patients that are between 34 and 36 weeks, that hospital will still send those patients to Denver. They will not send them here. The animosity between the administration of that hospital and our hospital their physicians are told that they cannot send their patients here. So, you know, creating a regional system of care where everybody's on the same team and everybody's trying to do the best thing that they can do for the state of Wyoming and the citizens of Wyoming is a really intriguing idea. And creating regional centers that are accessible to, you know, the rural areas that are not going to ever have a hospital in their community. You know, you're never going to have a hospital in some of the smaller communities in Wyoming, but having a hospital that's close enough for them to access where there's programs in place that get them access to that care, I think is a really intriguing idea. And some of the data that was presented today on the deliveries in Thermopolis, those deliveries in Thermopolis are coming from Riverton because Thermopolis is sending providers to Riverton to provide prenatal care in that community, and the patients thus go to the hospital in Thermopolis to deliver. And that sort of outreach care, I think, is really important and intriguing. The problem is I have too much care to provide in my own city to be able to go do outreach care as well. So we're back to the ability to have enough providers to provide all the care to begin with. And with some of the comments about locums coverage, et cetera, I just wanted to make it clear that there's a nationwide shortage of OBGYNs. So there are not a lot of OBGYNs just sitting out there waiting for someone to offer them a big paycheck to come work in Wyoming. I get multiple recruiting emails, letters, phone calls every day for people looking for locums coverage throughout the country because they can't find OB-GYN providers to cover their own hospitals and clinics.
Thank you, Ms. Sheridan. Very insightful, and I appreciate that. Yes, Representative.
Madam Chairman, thank you, Dr. Sheridan and Mr. Porter. You heard my question to Mr. Bonenblust. He said, ask people who actually recruit. So the same question I asked Mr. Bonenblust to you too, if you remember.
Madam Chair and Representative Yin, could you remind us what that question was?
Madam Chairman, Mr. Porter and Dr. Sheridan, so the question was, we've been passing abortion bans perennially since the fall of Roe. Does that affect recruiting in the state of Wyoming?
Thank you, Madam Chairman, Representative Yin. So Wyoming has historically been a fairly low access to abortion state to begin with. There are not many providers in the state of Wyoming that provide abortions to begin with. However, it's really important to understand that when you put things in legal language and legal jargon that you don't have a full understanding of the terms that you're using, you put people at risk. And you saw in some of the data earlier today that Idaho decimated their physician population by passing strict abortion laws that put providers at risk. Not because most of those providers wanted to provide abortion or were even providing abortions to begin with. It's because you're limiting their ability to provide the basic care that needs to be provided. So just as an aside, do any of you know what the ICD-10 code is for a miscarriage? It's spontaneous abortion or missed abortion. You're using medical jargon in the wrong way in legislature, which puts people that are providing care at risk. When you pass a heartbeat bill, you're telling me that I can't treat an ectopic pregnancy because the fetus that's growing in the tube, not the uterus, has a heartbeat until the woman's bleeding to death. That's important. You're going to criminalize me for doing the right thing for a patient before the patient's dying. So absolutely, those laws are very critical, and how you word those laws is very critical to the providers who are providing the care on the ground. Most of us would say, I'll treat the patient, I'll deal with the legal part later. But the fact of the matter is, there are a lot of people out there that are too scared to do that, and so they just won't come. And you see that in Texas, some of the lawsuits in Texas that physicians have let patients die because they were too scared of the legal outcomes.
Any other questions? Okay, we are going to take a 10-minute break. Thank you, everyone. Okay, we're going to, I'm just going to ask if there was any more public comment for maternity care provider issues, and if not, we will move on to behavioral health providers. Is there anything else? Mr. Gomez, you're just moving? Okay, just moving, okay. Okay. All right, thank you very much. Was there anyone online? No? Okay, the next topic is behavioral health provider shortage, Wyoming Department of Health. Deputy Director Fuchs.
Thank you, Madam Chairman. Members of the committee. We just have a very short slide deck asked to present on this topic. We don't have any specific expertise or anything in here to offer besides some data analysis we did on, looking at taking licensure data. So from the two boards, the psychologists and also the licensed mental health professions. And we put our slide deck together. All it is really kind of trying to portray trends over time and per capita, and just some interesting, we just present it as the data as we found it. We have no really education or comment to add to it. But it starts on slide 23 or deck, and I'm not zoomed in, Katie, I'm sorry. Okay, hopefully LSO can display it. But what we have on slide 24, and Madam Chairman, I don't know if you want me to pause and wait for it to show up on the screen or not, or if you'd like me to just proceed.
Mr. Fuchs, what would you, I think it's coming. Okay. We're almost there. If you'd like to
Almost there.
proceed. Yeah.
So slides 24 and 25 just show the raw counts of licensed independent PhD level practitioners by county. So these are psychologists, and then there's a new, I think it was a few years ago, licensure category for behavior analysts was added to the Board of Psychology. And so we've sort of categorized that as the green and the reddish orange there. The only observation we have is that the counts seem relatively stable over time. It doesn't appear to be much growth in these PhD level independent practitioners. To the contrary, we have on the next slide, the master's level practitioners. These are LPCs, LCSWs, and LMFTs. You can see there a stacked area chart by county and the growth over time there. So there has been some growth in master's level clinicians over time by county, although obviously some counties have next to none. And then we looked at it on a per capita basis. So slide 26, a bit of an eye chart, and you can see each line is a county. So the PhD levels on the pane on the left. And I thought this was interesting. If you look at it, Teton, Albany, Uinta, and Sheridan counties have that grouping of a per capita PhD practitioners that's significantly higher than the rest of the state. So there's really just two groups of counties in Wyoming. You have that group of counties, and you have everyone else when it comes to the PhD level.
Okay.
Uinta County, I believe, is included there because we have so many psychologists at the state hospital. So I'm not sure that's a really inpatient service per se. I will say the limitations of this data, this is really using the licensure data, and it's using the mailing address. So these may not be practicing, they may not be taking patients, they may not be taking private insurance. It's purely the count of licensed practitioners per this board data that we've merged with population data to present these slides. So I want to be clear, there are significant limitations as far as inferring any access or shortage kind of takeaways here.
Okay, thank you.
On the master's level, you can see there's definitely a more of a gradation. There's not just two clumps of counties there. I will say probably Goshen County has a high rate probably because of the prison in Torrington and the behavioral health requirements there. So I think the state facilities significantly influence, if you have a state facility that hires a bunch of folks, that's going to influence these county rankings significantly. But again, Albany, Sheridan, Johnson, Teton, at the higher ends of the spectrum on a per capita basis.
Okay.
We find this corresponds to physician shortage as well. Generally speaking, these kind of counties have higher physicians per capita and thus not much of a shortage of physicians, like Teton County, Sheridan County, and tend to be the most scenic areas of the state tend to attract PhD and physician type in a disproportionate manner compared to less scenic parts of the state, like my own. That said, again, distribution there. Again, we present these slides without comment. We just wanted to provide some data for you to chew on as you consider behavioral health shortage as a topic. So with that, Madam Chairman, happy to conclude.
Thank you, Deputy Director, for all your work. Appreciate it. Is there any questions for Mr. Fuchs? Thank you very much. Will we see you tomorrow?
Madam Chairman, we'll be zooming in tomorrow.
Great. Okay, safe travels. Rural health? Is that what? Is that what you folks were here for? Yes. Okay, next topic. And thank you again for staying. I know it's later than thought, but the co-chairman mentioned labor health is like that. We have a lot of people that are very interested and a lot of agencies. Thank you. Representative Thayer, did you have something?
I believe your mic, Madam Chairman, your mic must have not been on. I could not hear anything you just said, your last statement. I just wanted to let you know about, I didn't know if there was a problem with your mic. Thank you.
The problem was the operator.
Okay. Late in the day.
Okay, thank you very much. Yes, please introduce yourself and let us hear testimony.
Madam Chairman and committee members, thank you for having me testify today. I appreciate being here and I appreciate the honor of talking about behavioral health programs through WICHE's behavioral health program. My name is Todd Helvig. I'm a clinical psychologist and I am an employee of the Western Interstate Commission for Higher Education. We have a behavioral health program and I'm the Director of Education and Training for that behavioral health program. Wyoming, like many of the other states in the West, faces significant behavioral health workforce shortages across both urban and rural counties. One of the ways that WICHE's behavioral health program has proven to increase behavioral health clinicians and clinical workforce is to grow and retain that behavioral health clinical workforce by expanding in-state clinical training. Those opportunities, especially through accredited doctoral psychology internships. So today, I would like to share with you a little bit about how WICHE supports multi-site internship consortia, the outcomes that we've seen to date, what a consortium could look like in Wyoming, partnerships with state clinical providers, institutions, et cetera, and the timeline and costs associated with developing a psychology internship consortium. You can go to slide 2. I'll talk a little bit about WICHE up front, for those of you who don't know who WICHE is. The Western Interstate Commission for Higher Education, commonly referred to as WICHE, was created through the Western Regional Educational Compact, which was established by the Western governors in 1951. This compact was ratified in 1953, and that language is embedded in the state statutes of all member states and territories. The legal foundation is important because it establishes WICHE as a state agency in each member jurisdiction. This compact is the cornerstone of our identity and reflects our commitment to regional collaboration. Slide 3, please. Our mission is to work collaboratively to expand educational access and excellence for all residents of the West. We do this by promoting innovation, cooperation, resource sharing, and sound public policy. Slide 4, please. WICHE's region stretches from the Dakotas to the Republic of Palau, covering 15 states, U.S. Pacific territories, and freely associated states. We unite around shared goals in higher education, workforce development, and economic vitality, leveraging our broad perspectives to create solutions that benefit the entire West. Slide 5, please. WICHE is governed by a commission appointed by the governors of each member state and territory. Each jurisdiction designates 3 individuals to serve as commissioners, and the commission has 3 primary responsibilities: providing strategic direction, holding fiduciary authority, and evaluating the president. This governance structure ensures that WICHE remains a collaborative, member-driven organization with decisions guided by the priorities and needs of the states and territories we serve. Slide 6, please. Wyoming's 3 commissioners are Fred Baldwin, Joseph Schaefer, and Mike Smith. Our strategic guidance and oversight help WICHE align programs with Wyoming's needs and strengthen collaboration across the region. Slide 7, please. We do have a legislative advisory committee, the LAC. It's an important part of WICHE's engagement strategy. Each WICHE state can appoint up to 4 legislators to this committee, and the LAC provides a unique platform for legislators to engage with peers across the region, explore pressing policy issues, and learn about emerging trends in higher education. It's also an opportunity to stay informed about research and data that can shape sound public policy. Okay, and Wyoming is well represented on our LAC. Our current board members are Representative Brown, Representative Washut, and Senator Schuler. I'm going a little quickly here so I can make sure to get all the good information in. Slide number 9. So this is what provider shortage looks like around mental health in Wyoming. And the interesting thing is that if you were to zoom out a little bit and look at all of the West, you'd see a lot of the states are much like this. It shows that you have provider shortage areas for mental health services across every county in the state. And the problem with that is that not only does it create rural and frontier access challenges, but you're also trying to get clinicians from the same pool as all the other states around you. And so it's very difficult to recruit new people into a state when there's so many. I think we heard some other speakers today talk about the same problem with other professionals in the medical industry, is that you're kind of pulling from the same pool of people. And so what we talk about is, how do you create programs where you can have that clinical training in-house in the state so that people come here or stay here for that clinical training. Slide 12, please. The University of Wyoming Doctoral Psych program is a 4-year program. It requires courses, comprehensive exams, thesis, dissertation, practicum, and the very last year of your doctoral program, you have to attend an internship, a full-year internship where you accumulate 1,500 hours of direct clinical service that's supervised by a licensed psychologist. Now, the interesting thing about that is that we have to find more and more internships in order to serve the population of the interns coming out of their doctoral programs, so that they have a place to stay or a place to do their clinical work. Do we have this slide? Yeah. Okay. Let me just switch over to my, there we go. Hold on a second. All right. Okay. So WICHE's a psychology internship initiative. About 16 years ago, WICHE began building psychology internship consortiums because of this very reason. There's interns coming out of these doctoral programs. It's their last year. They have to get a spot somewhere in order to put a capstone on their doctoral training. And so, in Alaska, they were having a lot of need for additional psychologists. And so we started building that clinical psychology internship so that those students could have a place to train in Alaska. To date, we have 10 internships across the West. I'm going to show you a graphic here in a minute that shows where those are located. But we do have them in Alaska, Guam, Hawaii, Idaho, Nevada, New Mexico, North Dakota, Oregon, and South Dakota, and Utah. To date, we have 41 internship slots available through those 10 internships. And we've graduated 376 individuals who have completed their internship and went on to complete their doctorate program and become psychologists. And 54% in-state retention of those interns in the area in which they trained. And that's kind of the key point that we're trying to hit home here, is that when we train people in some of these rural communities, many times they stay in the same area in which they train. Is the next slide, 11. I don't know if that's up, but this is a graphic I'm showing you of where our 10 internship consortiums are. And you can see how we have them down in Guam and Hawaii, up in Alaska, and then in different states across the West. So how does someone become a clinical psychologist? They have to enter a doctoral program. They complete all the requirements up until their final year. And if they're in good standing, then they go on their year-long internship. And they generally try to pick an internship that fits the training model that they've had wherever they've been getting their training education, wherever they've been getting their doctoral education. So they get into the program, they finish their years, they go on internship. In Wyoming, an internship is 1,500 hours. You have to have 1,500 hours in order to receive licensure later in your career. They also specify that their interns in Wyoming have to go to an accredited internship slot. And what we also try to do on the back end of internship are build postdoctoral fellowships. So if you've captured somebody for a year to do their internship and get their training in a rural community, and then you build a postdoctoral fellowship on the back end of that, that intern can, or now doctor can go into that program, then they get that additional year of training under supervision, and they continue to build their personal and professional lives in that community. We find a lot of times people end up staying much longer and end up building themselves into that community based on those relationships. So how the consortium model works. Well, so what WICHE does, what our behavioral health program does, is the first thing we try to do is find out who the partners are going to be, who the relative partners want to be, that want to have an intern at their site, that want to train an intern, and that have the capacity to train an intern in their site. And so those partners could be hospitals, healthcare systems, community mental health centers, state and federal agencies, university-affiliated clinics, inpatient psychiatric facilities, or rural clinics, all of the above, whatever it is, wherever it is, that we have the staff and the ability to train an intern, and we have the motivation from the organization to have that intern them and to train them to competency is what we look for. What WICHE provides is the shared infrastructure. So we have a long history of putting these internship consortiums together. We can come in with the standards and the principles and the things that that internship needs to have in place. We help pull those partnerships together between provider organizations, provide administrative coordination, accreditation and compliance support, recruitment and national match participation, and technical assistance and consultation. So we basically come in with all of the foundational work that an internship needs to have so that we can push that internship as soon as possible to accreditation, which is going to attract more interns and more of the behavioral health workforce. So when we look at the roles and our expectations about the roles that different players would have in developing an internship consortium, things you can think about is that the state of Wyoming would probably be looking at funding, how they could fund an internship consortium. How does it align with your workforce initiatives and the public policy that would support an internship? Clinical providers would have to provide some training sites, service delivery model, supervision and training for the interns. WICHE again helps build the infrastructure, provides the administration and accreditation support, and helps with technical assistance. And for example, if we were to access the University of Wyoming, we could again develop not only those relationships, but hopefully try to keep some of those students who are training for their doctoral degrees in Wyoming for their internship, and then potentially even for their postdoc. And then you've got this person who's been trained here, lives here, works here by Wyoming for Wyoming. One of the things that I love that structure that I just presented to you because it does mean that we can keep those folks who train here. But one of the caveats to that is that for the accreditation of these programs, many of them, they all have to go through the match process. And the match process is coordinated by APIC, the Association of Psychology Postdoctoral and Internship Centers. That organization has every potential intern rank all of the internship sites that they have interviewed with and want to go to. And then they have the sites themselves rank the interns that interviewed with them. And then through some algorithm that they've created, they match each intern with a site. And so that's the caveat that I'll throw in about having University of Wyoming students going to the internship, is that certainly that relationship would be there where we'd probably have more interns or potential interns being interviewed for those slots. But there's no guarantee, is what I'm trying to say, that just because interns or just because doctoral students trained here, that they'd get the internship here. But there's other factors, because not only are you training those folks who have trained here, but you have the ability to bring interns here who have been training at other universities. And so they might be coming here to do their internship, and then they would be putting a stake in the ground where they wanted to develop their personal and professional career. And the other thing is it's a bridge back home. For all those individuals who go to some other university to get their training and education in psychology, they might come back home to Wyoming to get that final capstone on their doctoral training. All right, this is slide 16. Preparation for accreditation includes applying for accreditation membership, writing and submitting a self-study for program evaluation, responding to self-study feedback from Commission on Accreditation and reviewers, preparing for and hosting an in-person site visit to verify program details and processes as outlined as a self-study. So these are some of the things that we do to stand up an internship. The startup usually, it takes 18 to 24 months. This is a long-term strategy for developing workforce. It really is. It's one that you're not going to expect to see it happen tomorrow or maybe within the same year that we started. But certainly over time, as we build the internship and we start getting the workflow of the interns into the program, then it builds and it gains momentum along the way. So certainly that startup phase includes determining participating organizations, designing the training program alongside the clinical supervisors, developing policies and evaluation systems, and preparation for accreditation. And then the ongoing costs that you have to expect are the intern stipends, because you have to pay them to be there for that year and provide benefits, the supervisor and faculty time that's necessary, and any administrative and compliance operations that need to continue to go on for the long haul. So the role of internships in workforce recruitment is to increase the number of internship opportunities for all graduate students, but especially it could work for the University of Wyoming as well, the students coming out of the University of Wyoming doctoral PhD program. Also to enhance national visibility and strategic growth, adds pre-licensure training capacity in the state, provides workforce retention pathway, and strengthens the pipeline to independent licensure in the state. So WICHE is proud to be a partner with Wyoming in advancing the state's education and workforce priorities, ensuring that every dollar invested delivers measurable impact. We're committed to maximizing value to Wyoming taxpayers and look forward to many more productive years of collaboration. Thank you for the opportunity to be here, Madam Chairman, and I welcome any questions.
Any questions for Mr. Helvig? Senator Scott?
Yeah. Now you've been proposing an internship program that think we ought to get into it. This is a sparsely populated state without too many private practitioners. Realistically, do we have enough volume to build an internship program here?
Thank you.
That's certainly one of the questions we have to explore. Sorry, Madam Chair, Senator Scott. It's certainly one of the data pieces we need to explore in terms of where it would best be located and who would participate in it. But with the relative shortage that you have and the fact that you do have providers across the state and you have agencies like the state hospital and you have the VA and you have the University of Wyoming and you have these different agencies who could conceivably participate in a statewide internship consortium. The beauty of this consortium is that it shares the resources. It spreads the resources around so that not one organization is responsible for the costs of putting the whole thing together, which is pretty expensive, as you can see. So when you can spread the resources and you can spread the supervision, you can spread the training around, you can spread the dollars around that are necessary in order to keep the internship going, it allows for that pressure not to be so heavy, even on smaller providers. So it definitely would take some exploration on our part, but we've done it in some very remote places with very few people in areas, and we've been successful in keeping those psychologists working in those communities.
Any other questions or comments? I have one, Mr. Helvig, and it is amazing to me. I'm glad you're here today because I have heard for 6 years now, WICHE and WWAMI, thinking that both were working within the state. So what I'm hearing today is that this is a presentation on how WICHE could work in Wyoming. Is that correct?
Right, a very specific program that WICHE offers and could develop within Wyoming. Yes.
Okay. Thank you very much. Okay, I don't see any other questions anywhere. Was there, let me see the next. Online, okay. Okay, who is online? Sheila Gallo. Miss Gallo, are you there? Oh.
Can you hear me?
Yes, we can.
Oh,
Can't
perfect.
see you yet.
Okay, well, let's see if I can. Oh, here we go. Thank you. Thank you. I'm glad I stuck around for this. So I'm Sheila Matthews from Able Child, and basically, we wanted to talk to you about this illusion that there's some sort of shortage of psychologists and behavioral health in the state of Utah. You had the director of health show you a chart that there's a saturation level in the state of Utah, that you do not have a shortage there. So one of the things I want to make certain that you as legislators is incorporating how to deprescribe and how you're going to incorporate this into the grant. Wyoming, I have some numbers here for Medicaid in Wyoming of 2023 that was obtained by a FOIA request, which is shocking because you would think that the association, the APA, and the psychologists would be providing you with this data, but it was FOIA'd by the Citizens Commission on Human Rights regarding the number of children in Medicaid on psychiatric drugs. So we have 5,986 children on psychiatric drugs at a cost of $5,794. And on stimulants, you have children, and this is 0 to 17-year-olds. On Medicaid, you have 3,475 children at the cost of $4,861,483.95. And then you have children, and that's on stimulants. Then you have children 0 to 5 in the state of Wyoming, 228 children on mood stabilizers, and that's costing $62,000. Then you have 0 to 5-year-olds on 103 at 26,541. So basically, you have under Medicaid, you have a expenditure of over 10 million, almost $11 million on psychiatric drugs for children in Medicare. Okay, as young as 0 to 5 that are on mood stabilizers. So you have to look at the diagnosis. You have to say, how is a 1-year-old being diagnosed and being on a combination of psychiatric drugs, mood stabilizer, and a stimulant? So when we look at your presentation that was just given, I would run from that presentation as lawmakers, because the National Defense Education Act needs to be addressed here. You have children that are minors in Medicaid that don't have informed consent. These become lifetime clients of the psychiatric industry and the pharmaceutical companies. And there's no way out for these children. And they often go into homelessness after the state no longer pays for their psych drugs and they age out of the system. So I would caution you very strongly to take the money that you're even thinking of looking at this presentation and incorporate Secretary Kennedy's deprescribing. Because without the right, these children in Medicaid don't have the right to say, I don't want to go on a psychiatric drug. Okay, so we are getting more and more children on these drugs without an exit plan. So this subject is very dear to consumers. Able Child did a 1-year-long study with Diane Sawyer, where children in foster care under Medicaid were on a combination of these drugs. I'm happy to provide your committee with the FOIA numbers that we have received from your state. But what concerns me here is that the professionals that are prescribing these psychiatric drugs to Medicaid recipients, aren't providing you with this data. We've, as human rights organizations, as parents, we're not providers. I sat here all day, and there's some really scary things that parents need to know about, and that's informed consent. So I would ask you to look at the numbers of children on Medicaid, on psychiatric drugs, and how this particular presentation and all the ones before you today didn't incorporate that as a data point at all, at all. And so we're here to do that. We're here to do that as consumers and parents in Wyoming that are being placed on multiple drugs without their consent because their children are in state custody or they're on Medicaid. You are the watchdogs. And so we're asking for you to be realistic here. I found it very interesting that the director's assistant gave you a map of a saturation point. There is no shortage. What there is a shortage of is informed consent. And so we would ask you to start to de-prescribe in the state of Wyoming. And that is where your focus should be and your dollars should be, because again, these children don't have a voice. They're being told that they need to be on these psych drugs, cocktails of them, by your providers in the state. So this is a human rights violation of a huge degree, and it is affecting the nation because, again, we presented earlier in the day is that tutoring, language, communication directly affects behavior. And just because you have parity, mental health parity, you as lawmakers can decide what affects behavior. So we're asking for tutoring for children, not telehealth, where your own director is concerned about these ketamine factories that are not regulated in the state of Wyoming. We're very concerned and parents are very concerned. So I'm glad I stayed on, and I'm willing to work with this committee. Able Child represents several families in Wyoming, and we really want informed consent. We don't want you to spend any more money on mental health. You're saturated with it, and it's a monopoly. So I would ask you to seriously consider some human rights and to really focus on these Medicaid numbers. You as lawmakers should be saying, why don't I have these numbers? Why does Able Child have these numbers? So that's what I would ask. And then one more thing. Psychiatry and the psychologists that are putting these children on these drugs in Medicaid, they have no legal recourse. So when you talk about tort reform, I have to tell you, there has to be an avenue in which a consumer of mental health and behavioral health products and services in the state of Wyoming can sue for misdiagnosing and doing a polypharmacy that is off-label and not FDA approved for use in children. So with that, I really thank you for staying late. I know you're volunteers. Able Child really enjoyed working with you guys on some of the data that we brought regarding a bill. And we're looking forward to getting the data like the Tennessee on the mass shooters that have therapeutic levels of psychiatric drugs in their system. So we want to do prevention, and that starts with informed consent and curtailing the Medicaid drugging of children. So thank you so much.
Thank you, Ms. Gallo. Senator Brennan, question? Oh, a comment? Go ahead.
Thank you, Madam Chairman. I thank you for your testimony. I do want to just point out and clarify, I think it's very important that psychologists and psychiatrists are different in their scope of practice and what they can and cannot do. Our presentation was on psychologists, and psychologists cannot prescribe medicines, to my understanding. That's the job of the psychiatrist. Is that?
Well, the numbers, I appreciate that, but the numbers of Medicare children are a problem in your state. And the medical director's assistant showed you a saturation of that industry as well. So there isn't a shortage, and the consumers want legal protection from these labels and these drugs.
Thank you. Any other questions or comments for Ms. Matthews Gallo? Senator Hutchings.
Thank you, Madam Chair. I, for one, really appreciate your presentation and offering us a different perspective. We tend to see the same people or the same ideas come through over and over and over again. And I think we know our kids are being drugged, and like I say, your information was very important, very much appreciated, and you can send Senator Hutchings your information, and I'd love to read through it, just even for just my own sake. But we have to open up our eyes. This isn't something that is not happening. It is happening, and thank you for your presentation. Appreciate it.
Thank you, with so much respect that you're inquiring.
Thank you. Ms. Semino. Did she sign off? Okay, are there any, oh, we have a few more. Okay. Please come up. Okay. Thank you, Mr. Hubert.
Good late afternoon, Madam Chairman and members of the committee. My name is Clark Fairbanks, and I'm with the Wyoming Youth Service Association. We'll be very brief, and I'll let Mr. Anderson introduce himself and speak first. Thank you.
Madam Chairman, members of the committee, I'm Ryan Anderson. I'm the Executive Director for Youth Emergency Services, the S House up in Gillette. We serve some of the highest risk youth in the state that are kids that are ordered into state's custody for providing residential treatment for those youth. Speaking to the behavioral health provider shortage, we've had vacancies over the past 2 years that we have not been able to fill. Feel that there are several factors that we're seeing that have exacerbated some of the shortage of mental health providers. One of those factors that we've experienced recently is just the process of licensure is oftentimes takes excessive amounts of time. It's a very manual system at this point, paper and pen, filling out applications, sending it through the mail. One of the things that would greatly assist with that is a modernization of that system. Many of the professional health or professional licensing boards, it can be done on a more automated basis with things being sent in, and so that is something that we have seen in that process can take a long time, and obtaining that licensure, when it takes a long time, sometimes we lose candidates. Sometimes people choose not to come to Wyoming because they're applying for multiple jobs in different states, and so they can be going to other places, which is unfortunate. And then one of the other things that we have done as an agency to assist with trying to bring more providers in is we now pay for a good portion of our staff members to go to school to get their degree, whether it's a bachelor's level of social work or a master's level of social work. The unfortunate side of that is that they're all taking their classes online. And so none of them are able to, those dollars leave the state of Wyoming because they're often going to to online schools because they can't uproot their life and leave Gillette or other places and go to Laramie. And so not being able to have any sort of access to an online program through, Wyoming's only state institution is something that does affect that. Fortunately though, we are able to help them with that and provide those internships. And oftentimes these are bachelor's level and master's level programs that they're obtaining, and then we provide that internship. And so we have 5 of our staff members right now that are actually going through through either their bachelor's or master's level programs. So that is one thing that we're seeing. But one of the things that this committee could help and support is supporting the University of Wyoming and expanding up a program, whether it's in social work or a licensed professional counseling program. And with that, I'll turn it over to Clark as the director of Wyoming Youth Services.
Just in the interest of time, then when I'm done, you can ask either of us any questions that you might have. I'd like to give you a little broader overview of the issues that the Wyoming Youth Service member agencies face when it comes to the behavioral health shortage. We represent 17 member agencies, all nonprofits, working with kids across the state of Wyoming, providing prevention, intervention, and treatment. And obviously, the fewest number of kids we serve are at the highest levels of care. At the prevention level of care, we're serving the most kids and families in Wyoming, and that's what we want. I provided a handout to you. I think LSO provided you that maybe a little after lunch. It's got some circles and numbers on one side. On the other side, it really has information on the number of youth that we served last year. So the highest level of care is psychiatric residential treatment. And the provider that is a member agency served 109 children and families, and 95% of them completed treatment. Next level is qualified residential treatment. Brian spoke to residential treatment with families. Those are spread across Wyoming. They serve, and BOCES also are included in that, served 134 Wyoming children last year. 93% of them successfully completed, returned home to a family member or foster care. The group homes across the state, many of your communities have crisis shelters and group homes. The group homes served 225 youth, crisis shelters 1,192. Those are families that are in crisis that need immediate support for a short period of time. And then intervention, which includes outpatient counseling, day treatment, wraparound, family care coordination, and forensic interviews, served 5,547. So I just want to give you a picture of the Wyoming Youth Services and how critical it is really providing frontline support, care, treatment for children and families, and keeping those children in Wyoming and helping them be successful. In addition, we also, in many cases, provide educational services when kids are in out-of-home care. Our member agencies employ 582 employees. And we, as this paper shows, at a snapshot, when we pulled this information together, we had 77 youth care professional vacancies, which is roughly a 13% vacancy rate. But our turnover rate is much higher than that, and that's problematic. And that's why we're here, just to let you know that, and those behavioral health provider shortages, again, starting at the highest level care, are psychiatrists. Wyoming has a critical shortage of psychiatrists, especially child and adolescent psychiatrists. And that shortage at times leads to kids not getting the appropriate level of care, the appropriate assessment in a timely manner, which is really problematic for Wyoming families and children. And then psychologists. Psychologists providing psychological assessment that really help families understand what's emerging, because we're talking about kids. Many of those issues are emerging, and families are trying to understand what's the appropriate help that they need. And so psychologists are a critical role in our system of care. And then licensed professional counselors. I would just note, it's specific to those who are willing and able to work with child and adolescents. So we saw a presentation on the number of licensed professional counselors. Not all of them want to or have the expertise to work with children with significant trauma and significant mental health issues or co-occurring issues. And so that's a factor for us as we work to provide timely, appropriate care for children. Just a couple things that I want to highlight in that shortage. One, there's a national shortage of mental health providers, but it's compounded in Wyoming. And part of that is many providers are unwilling to accept Wyoming Medicaid and Wyoming Medicaid reimbursement. So that you have another factor. Not only do not all providers can see children and adolescents, some won't accept Medicaid. And Wyoming's system of care for many of those kids is provided by Medicaid. Mr. Anderson spoke to the limited number of advanced degree programs in Wyoming and the limited number of slots. Doesn't meet our needs. It doesn't replace those who are retiring, let alone those who are moving out of state. The delay in licensure, again, reciprocity. I think our reciprocity might be easier leaving than it is coming in. Many times those degree programs don't line up, and the delays, as Mr. Anderson said, often leave people, they just professionally can't go months without a paycheck. They'll go somewhere else. And then I just want to touch on adequate Medicaid reimbursement. Wyoming went nearly 12 years without an increase in what we compensate behavioral health Medicaid providers. And in fact, in that 12 years, there were 2 cuts that accounted for 5%. All of you in business know cost increased over those 12 years, not to mention insurance, malpractice insurance, and health insurance. I would like to recognize, after several years, Department of Health has had a cost rebasing in their budget, and this year you passed a cost rebasing. So we want to thank you for that. We appreciate that. That should go into effect in July of this year, maybe in reimbursements then in August or shortly after that. And I would just say that I think that exacerbated some of our challenges with the shortage of behavioral health providers. And my hope is that we won't go another 12 years. And my advocacy tells me it would be really nice if we could look at that cost rebasing every 2 years as part of our budget process, because our kids and our families who are struggling with trauma, with mental health needs, substance abuse needs, really need those services. And with that, I thank you for your time and would stand for any questions that you might have for us.
Thank you. And I wrote down here, Clark. What is your last name?
Fairbanks.
Oh,
Thank
that's
you.
right. Okay. Any questions or comments? Senator Scott?
Okay. 2 questions. One, very simple. You're talking about extra time in getting licensure. What kind of time frames are you talking about that they're doing? Because that is something we can maybe light a fire under them on or change their licensure system. That's something maybe we can deal with. Second, I'm one who does suspicion that the education system in particular is pushing over medication of a number of children. But it strikes me that the ones that wind up clients and your members have serious mental illness problems that are not related to that. Am I right in thinking that that's correct?
Madam Chairman, Senator Scott. Yes, so just to address the first question, the time for licensure, the thing that we have seen, and granted, I've spoke to some of our other WISA agencies and other peers in our field, and it taking multiple months to obtain licensure, and I have worked. It didn't wait to come to this committee to bring that issue up. Have brought it to Curtis Biggs at the governor's office and some other areas, and worked with Ms. Simoneo as well. But and so yes, we're certainly wanting to advocate to try to reduce that time down, because the longer that those providers are without their licensure or they're sitting in limbo, the more likely we are to lose them or potentially lose them to other states. And so we have worked with that, and the folks at the professional that mental health licensing board have been available to kind of discuss some of the issues that we've been seeing. And it's just unfortunate it takes longer than we would like to have those things resolved, certainly on the multiple month timeline. And so, yes, we would certainly support and advocate for, a modernization of that system where, it's a little bit quicker and certainly a little bit easier for the providers to have access to. And then on your second question on over medication, the youth that we serve, as I had stated, these youth are court ordered into state's custody. Oftentimes they're in the custody Department of Family Services. They're placed into our care, so we have physical custody there. But I can certainly speak on the behalf of the Yes House. Our youth ultimately have the say over whether they take a medication or not. They can refuse a medication. They can say, I don't want to take this anymore. And we work with we use a psychiatric nurse practitioner. So again, we don't have access to a psychiatrist because of the limited there. And so we use a psychiatric nurse practitioner. But our youth advocate for themselves in that, and they work with the parents as well. Anytime a medication is changed, we do not change that medication until both Department of Family Services and the parents have been contacted and have authorized that. And we have had cases where the parents have said, no, I do not want my child on that, and we work with them on that. And so I can't speak to all the providers across the state, but I think a lot of times we have very similar practices, and on the Yes House's behalf, that is our practice.
Thank you, Mr. Anderson. Follow up, Senator Scott?
Am I right in thinking, though, that the kids that you're dealing with are severe enough so that we're not seeing over medication as a major problem?
That is correct, Madam Chairman, Senator Scott. We don't see the over medication as a problem. A lot of times we see, sometimes they're coming to us from out-of-state facilities, and maybe we're taking them off some of those medications because they have been over medicated at some point in time, and so we work to do that. And then also, there are some great technologies out there now where there can be testing done to see, is based on the child's particular, I wouldn't say genetic makeup, but type of testing to see what prescription would work best for them as well too. And so that helps a lot with not ending up in, okay, let's try this one, wait several weeks and see that, okay, it's not working and there's more frustration. And it helps a lot with not ending up in some of those bad situations.
And
thank you.
Madam Chairman, just real quickly to follow up on that, I just, on the data that we talked about, I think, so at that highest level of care, talking psychiatric and qualified residential treatment, those are the highest level kids and the most severe needs. But our member agencies do a tremendous amount. If you look on the sheet, they served 11,000 kids in prevention. And those are kids that are not on medication. They may not be in counseling. They're in after-school support programs education, supplemental education programs, behavioral programs, parenting classes, a whole host of services. So I just wanted to put a plug in for our member agency is really there to support kids and families without placement. But when placement is needed, we want those kids to stay in Wyoming, closest to their family, closest to their church, closest to their sports. And the reality is, if you haven't had a child who's faced significant trauma or mental health needs, I mean, we know that that's a blessing, but it is not always the case for our children in the state who do need our help. And so we really work to be there for them, provide the education. They have choice, and parents and kids make those decisions. We provide them with options and information, and services is really our goal, but we're not making those decisions for them. So, thank you.
Okay, thank you. Representative Clouston.
Thank you, Madam Chair. Gentlemen, thanks for being here. So I assume you're going home tonight, but hit the drive again. If you could speak a little bit to how a child ends up in your facility. And my concern is when we don't have enough professionals to treat these kids, what I want to make sure is they're not sitting in hospital rooms or sitting in jail cells for extra days because we don't have the resources to help these kids. So just let me know if that's a valid concern. And then again, a little bit about how a student ends up at your facility.
Madam Chairman, Representative Clausen. Yes, when there isn't, I mean, one of the things we talk about is our continuum of care. Like we really refer to everything from early prevention and intervention on up into treatment. And oftentimes what we see was when a youth doesn't receive services early on, and maybe that's just seeing a counselor, seeing a licensed professional counselor or a LCSW in an individual therapy session, or receiving maybe a substance abuse assessment much earlier on. If those youth fall through the cracks, they just don't go away, right? I mean, they kind of pop up further on in the continuum of care, and a lot of times our concern with that is then you have more significant behaviors, potentially more substance abuse, more trauma that's occurring, and then they end up in a more costly placement. You know, being in a psychiatric residential treatment facility, or having more behavioral or conduct related type issues where they may end up in the state of Wyoming boys or girls school. I mean, that is certainly a concern that we always have. But I mean, as providers, what we really advocate for is serving them at the lowest level possible and closest to home. And so that's why, I mean, having those resources in those communities, supporting those crisis shelters, because sometimes, and one of the things I say is, you know, sometimes those kids just need a break, and they need, you know, the parents and the families, they just need a little bit of time of separations. And then we bring them back together, have a family meeting, talk about what are the resources out there in the communities that those crisis shelters can connect them to or provide. Oftentimes, you know, sometimes maybe the party that's really struggling is the parents. If we could provide a crisis shelter for parents, that'd be great. But we do the next best thing, which is we provide a crisis shelter for the youth. And so by giving them that little bit of time and space, then getting them back together and saying, let's try this. You know, maybe it is an individual counselor. Maybe it is, you know, working with a program like a mentorship type program and giving them some other resources. So when there is a lack of those services in smaller communities and in some of those other places where maybe there isn't enough licensed providers, then, you know, then there's basically less tools in the tool belt, right? I mean, you know, if all you have is a screwdriver, you're gonna end up trying to pound in nails with the end of a screwdriver, and trust me, that doesn't work very well. And so just what we really want to advocate for is having the most options out there, because, you know, maybe a crisis shelter isn't the best resource for a family, but maybe seeing a counselor is, maybe a wraparound provider is.
Okay. I have one question for you. Are either of you part of or affiliated with or know about the Wyoming Resource Center in Lander? That seems to be advanced care, but
Madam Chairman, yes, the Life Resource Center, and we've, we're familiar with that. I mean, they often do, work with very high needs level youth and young adults and adults. That is something that that we're familiar with. Oftentimes, we refer to other places because if we're not the appropriate level of care, and working with Department of Family Services, I think Department of Family Services also places there at that Life Resource Center as well. Yes.
Senator Hutchings.
Thank you, Madam Chair. Either one of you can answer this question. Are you familiar with, I think it was Meadowlark Academy in Cheyenne? Is that part of your programming, or was it?
Madam Chairman, Senator Hutchings, we certainly are aware of, I think we have a good working knowledge of all the providers. They are not a member agency as they're a for-profit agency, and for Wyoming Youth Service Association, we only represent the nonprofit, local community-based nonprofit youth service agencies. But they are a provider group that's part of Wyoming Services.
Thank you.
Thank you. Any other questions or comments for Mr. Anderson or Mr. Fairbanks? Yes. No? Thank you.
Thank you very much for your time. I know it's late and you're appreciated.
Thank you.
Is there any other public comment or? No? We're done. Ladies and gentlemen, I believe we were at the end of our agenda for today. Thank you very much for being here and good night.
Madam Chair.
Yes.
Oh, just one more comment. Something that's been said throughout the day, I just couldn't let it go by. And I'll try to be really quick. Wyoming is a really rough place to live, like Alaska, and you have to really love it to come here, work here, and stay here. I've listened to the presenters talk about tort issues, spouses having jobs, places to go, things to do, practicing your craft, etc. And I have to say, I don't recall anybody bringing up abortion for any physician, doctor, whatever, as a factor to keep them away from practicing here in Wyoming. It seems like the constant need to subsidize and incentivize people to stay, it's going to cost us a lot of money to keep people here. And this seems like it's just going to be a really, really, really big issue. So I just wanted to say that and get it off my chest. So thank you. And I'm ready to go home.
Thank you, Senator Hutchings. Yes, it is a very big and very important topic for all of us. So, all right. We will recess until tomorrow morning at 8:30 a.m.